We have plenary sessions. हाँ.
हो
4,800.
for more than 4,700 people.
हे बघ, we have
नाही सर ते मी सांगतो.
ठीक आहे. इरेक्टाईल डिस्फंक्शनवर पण आहे. बरं ठीक आहे म्हणणं
सर असं मागच बसा सर रिलॅक्सिंग मागच सरकून बसा टिकून बसा Good morning everyone. I am Dr. Pradyumna Vaidya, Organizing Secretary of DermaCon 2020. With me is our Organizing Chairperson, Dr. Narendra Patwardhan. Welcome you all to DermaCon 2020. This is a novel concept which we have introduced about Derma TV. Sir will talk about, sir, how you feel this Derma TV concept?
नमस्कार, मी डॉक्टर नरेंद्र पटवर्धन. डर्मा टी व्ही हा पुण्यामध्ये किंवा या डर्माकॉनमध्ये पहिल्यांदी आपल्याकडे इंट्रोड्यूस झालेला आहे. याच्यामध्ये आम्ही सगळ्या एक्सपर्ट्सची मुलाखती घेणार आहोत अँड वी विल बी टेकिंग इंटरव्ह्यूज ऑल द एक्सपर्ट्स बाय आवर ओन डेलिगेट्स.
Yes, and one more thing, what that Derma TV concept, what I feel is, while we are giving lectures, we can talk only about evidence-based medicine.
Exactly.
And in this Derma TV, what I feel is that we will share our own experience, how we treat the patients.
Exactly. So this is the reason, and plus there is no time limit.
Yes.
Okay, so you can have a normal chat, you can have discussions, and we can have lots of things which probably were not covered in the talks, in the plenary sessions or in your own workshop. And that is the highlight of this TV.
Yes. And sir, what you feel about DermaCon 2020? It is coming after almost 33 years to Pune.
Yes.
So how you feel about that?
We are the proud hosts of DermaCon 2020. And we are all thankful to our IIDVL and IIDVL delegates. Yesterday's program was just an amazing program, which was designed by our organizing scientific chairperson, Dr. Dhanashri Bide. And we had CMEs and workshops on scar management, workshop on the PRP, workshop on hair
lasers,
transplant.
on pigmentation.
Exactly.
And see, and the best part of workshop, what we did yesterday was, we had a multi-entry pass.
Exactly.
And that was the first time concept it was introduced in DermaCon. See, what happens is, if I'm not interested in one of the sessions, I might skip over to the other workshop. So that was not allowed in the previous if I have not registered. But this time, what we did is we did that multi-entry, and that was a big success. Actually, and many people came and they gave us a feedback.
Right. What I liked was most of the halls were full. On the first day, we do not expect the halls to be full. There were little teething troubles in the morning, but we got over those, and all the halls were full. And the weather was too good, and I think people enjoyed, and I personally had a great interaction with my boss, Dr. Alex Ginsberg, in hair transplant, and it was well appreciated by most of the delegates.
And CME also, first time somebody was talking about clinical dermatology, which is slightly a neglected branch.
Right.
What I feel is, as dermatologists, whenever there's an Indo patient, we are slightly scared about managing that. And by this CME, I think many of us will be confident now to treat Indo dermatology cases also.
Exactly.
So that was also yesterday's quite nice highlight.
Yes. Along with that, we had excellent lunch It is spread over a larger area. People enjoyed the lunch. In the evening, we had a very nostalgic program of opening ceremony of
that is the main thing of the conference. The main there is an exchange of the baton from the old executive committee to the newly elected committee, and Dr. Narasimha Rao, which was our president till yesterday, he handed over it to Dr. Kiran Godse.
Yes.
Now he is our new president.
Along with the new executive committee. The main highlight of the opening ceremony was our chief guest, Dr. Deepa Malik, and the chief guest of honor was Dr. Mrs. Madhuri Kanitkar. Their speeches were appreciated by everyone. Yes,
it was so inspirational, to see her life, her journey, how she suffered and how she came over of that. It was an inspiration to all of us, isn't it?
It is the never to give up attitude, which probably, which literally put put a lot of glucose in our blood yesterday.
What do you feel? There was a standing ovation.
Exactly.
I think this was the first time he is chief guest getting a standing ovation.
The evening after that, we had felicitations of our IIDWL stalwarts, along with the felicitation of our two.
I felt very nice when we were felicitating our Pune patrons.
Exactly.
They have taught us, they have sent such a huge change in dermatology, and they have witnessed all those throughout this 35 years. So we are so proud to felicitate them.
And on the jewel in the crown was the cultural program.
Yes, absolutely.
Cultural program was absolutely amazing.
Absolutely. Marks and would see the energy which they had, the trumpet, the flute, and all those percussion instruments. That was mesmerizing.
Exactly. One thing I forgot to mention was observation of the leprosy day in the morning.
Yes.
We had a walk in the morning to make the people aware about what is leprosy. It was followed by the press meet on leprosy and steroid abuse.
And almost 30-35 reporters were there.
Come. And if they report it properly, probably it will go to a couple of thousands of people. And our purpose of achieving diagnosed leprosy early and stop steroid abuse in various fairness and anti-infective many people in this.
Through social media, through news channels, through print media. So that was an excellent thing.
And Pradyumna, coming for today's program, we are going to have a plenary sessions.
Yes.
And our main bowling will start today. Yes. We have all international speakers. We have a plenary
session. We have a huge academic
feast today.
Yeah, so it is very nicely organized, very nicely placed by Dr. Dhanashri Bide, who is our scientific chair, and her team, that they have worked so much. So I think people will enjoy the scientific
sessions. That will go up to 5 o'clock, and then we have a fantastic cultural program in the evening in the form of Derma.
Today's Derma Talent. Yes, again, this is very interesting. Like, there are a lot of talent in dermatologists, and they don't have the stage. So we are providing them a stage. So there will be dances performed by the dermatologist, then they will sing, then they will have stand-up comedians, that kind of shows they are having. Followed by, we are having Mr. Sudesh Bhosle.
And it will be with cocktails and dinner. So we all request you to join the evening program, enjoy the academic feast, and let us celebrate the first official day of the conference, DermaCon 2020 here.
Thank you.
थँक्यू सर.
हे कुठं बघायचं काय सांगा बाबा.
तुम्हाला तिथे झालं.
लेवल चेक करा की.
हॅलो.
गुड मॉर्निंग. ओके ना.
सो मॅम संपल्यावर ना सो आय जस्ट पुट दिस हँड अप बिकॉज आपण लगेच उठलं तर ते खूप अब्रप्ट वाटेल.
हो. retakes
But it's live TV. It's live.
No. This. Good morning, friends. This is Dr. Madhvi,
Hi, I'm Dr. Pradnya.
and we are here to discuss few of the regularly put up questions by the patients. And the most important thing, I believe, is the caring.
Hair care.
Yes,
Hair care to
definitely.
be specific.
Hair care.
Yeah.
And I believe we, the dermatologists, are at the best position to guide your patients to develop a routine hair care. Don't you think so?
Agreed, agreed.
Yes. And the first thing in hair care comes is the cleaning of the hair or maintenance of the hair by cleaning.
Right.
And when you say cleaning, I believe the first thing comes is the shampooing.
Yeah, it does, it does.
So, what do you think, Pradnya? How do you advise your patients about choosing the shampoos?
Well, ma'am, I feel shampoos are an integral part of hair care, and there's so many shampoos available today.
True.
But I believe that a selection of a shampoo based on its ingredients is very, very important.
That's also true, and I believe the selection of shampoo depending upon what type of hair you have.
Yes.
Like if you have a dry hair, frizzy hair, if you have a treated hair,
Correct.
oily scalp, oily hair,
Yeah.
and a mixed type or
Yeah.
normal hair.
Normal hair.
That also decides which type of shampoo
Correct,
to
correct.
choose, I believe.
And I believe that the patients with dry hair are the ones who are suffering the most, because any shampoo they use, it just dries out their hair, because any shampoo today consists of sulfates. Even if it's laureth sulfate, which is the mildest form of sulfate, it does cause them issues. So in that case, especially for women or men with dry hair, I ask them to look for ingredients like dimethicone, glycerine, coconut oil, argan oil.
And but the basic line while choosing your shampoo remains is that one should choose a shampoo which is totally sulfate free and which is totally paraben free.
Agreed. Yes, that is the safest, and it is the least alkalinizing. Least alkalinizing, which prevents the cuticles from opening up and therefore drying out the hair.
Yeah, and when the cuticle gets opened up, the delicate parts of the hair like medulla and cortex is directly exposed to the harmful sun rays and the harmful
Wind,
atmospheric
particulate
effects,
matter, yes.
which can really damage your hair.
Yeah. What is your take on conditioners? Because I have a lot of people asking me, conditioner se hair fall hota hai. What's your take on that?
No,
No,
I don't think so. But
I agree.
yes, I believe that more than the conditioner which is temporary, like we wash the conditioners immediately.
Right.
More than that, I believe I go for stay long conditioners.
Leave-in,
and
leave-in.
that is leave-in conditioners like serums. So I recommend a lot of serum use for my patients.
That's good.
Definitely. Because even if your hair is dried up and even if your cuticle is opened up, the serums will help in putting up the cuticles at its normal place.
Correct.
So that also makes the difference as far as appearance of the hair is concerned.
Right. I'd like to add one more
Yeah.
thing. In cases of conditioners, what a shampoo actually does is it causes your hair to get alkalinized, right?
Yes.
So I would prefer, and I usually ask my patients to look at look for ingredients like glycolic acid
Yeah.
or even citric acid in their conditioner, because that kind of brings down the pH of the
Yes,
cuticle to
definitely.
around 3.5 to 4, which completely closes the cuticle, therefore leading to that shine that everyone wants after a conditioner.
So one
So-
has to use a shampoo
Yeah.
for cleaning.
Yes.
One has to use a leave-on serum
Yeah.
which will condition. But one more important thing while you are using a serum is, I believe, the add-on sun protection factor.
It
which
has
they
also
add
sunscreen.
many a times.
Yes.
And yes, nowadays women are moving out quite a bit, and as the skin also needs a sunscreen, so also the hair also needs a
Agreed.
sunscreen.
Agreed.
So serum will also have a sunscreen protection also. But the gold standard remains is a broad rim hat when you really want to protect your face, your neck, and of course your hair.
It looks smart as well, you've got that chic
Yeah.
look with that hat
And
everywhere.
you can have a decorated ones also.
Yes, you can. So
Yes.
what do you suggest patients who ask for reduction of their frizz or the dryness with a cysteine or a keratin treatment? What do you tell
Well,
them?
there is a lot of boom about
Yeah.
straightening, rebonding, keratin treatment and cysteine treatment. I believe cysteine treatment is one of the latest ones, which includes the cysteine complexes, which is actually actually amino acids. But what is your take on this, Ramya? I
Well,
would like to know.
well, I had the opportunity to study it a bit, and for me, cysteine keratin treatments again involve alkalinizing the hair. It's actually deposition of those amino acids on the hair. So what it literally does is it opens the cuticle with a reducing agent. You add in that product.
Yeah.
And after the
Still
product
complex.
dries, the worst part of the treatments is when you straighten them out. So you have to use
need
extreme
iron,
heat.
Use the hot iron.
Correct, and that is where the damage occurs. So for me, if you have frizzy hair, cysteine keratin is not the way to go. I do understand if you want to cosmetically change your look, maybe you could try the cysteine keratin, but to reduce the dryness, using a cysteine keratin is not the way to go,
It's
definitely.
not the way, and then post-treatment care
Is
makes it
immense.
very
Yeah,
important,
yes, it does. And
I
it,
believe.
as your hair grow longer and longer, this hair is already dead, right? So as it grows longer, it gets even more frizzier, and then you end up doing the same thing over and over again.
True.
Yeah.
And one more thing about using any kind of hot iron or hot air dryer, again is very, you have to be very careful about it, because the hot temperature can damage your hair and can lead to bubble hair formation.
Right.
And these bubble hair formation, once it is there, you have to cut that hair.
Correct.
It cannot be repaired.
Correct.
So, guiding about the hair dryer use also, I would believe using a cold mode, if at all you want to use a hair dryer, makes sense,
Yes.
rather than using a
Hot mode. I agree, and that just makes life very simple. And I feel another thing I'd like to add for curly hair is the presence of dimethicone. Anyone with curly hair, if your patients are asking you what product to use, a leave-in conditioner maybe, or even a shampoo, you could suggest them anything with dimethicone, because it's a silicone. It kind of coats the cuticle and it smoothens out the frizz a bit without losing the curl. So it's a very good product for curly
when
hair.
you're using dimethicone products, again the combing also becomes very easy.
Right.
Detangling is easily
Yes.
done. So there is lot of, you can avoid lot of withering of the hair and again damaging the cuticle, and that also prevents the development of split ends. That is another problem.
Yes, split ends is something that a lot of patients complain of, and then they go actually cut their hair. It's like it's a tedious process. I don't know how they do it, but they do it.
Some they open it, you know.
Oh yeah, and then they kind of
Yeah.
cut. Yeah, yes, that also happens.
Yeah, I think we have covered a lot of
Yes.
important questions
Yes.
being asked in our daily practice. I hope the tips which we shared today on Derma TV will be helpful for you all to guide your patients to the right hair care procedure, to the right hair care protocol.
A regime. And another thing I'd like to however add is that every hair is different, you know, so you have to rope in the patient when you're consulting the patient and tell them that we are going to have to create a few combinations, try out a few products. There is going to be a little expenditure of money to be able to find out if a product suits you or not, but once you get the hang of how your hair is and how it functions, you will be actually able to use different products and maintain the hair as it is, you know. So
I believe, as I said in the very beginning, we the dermatologists are supposed to give them a skincare routine and a hair care routine.
Yes.
And once we plan it for the patients, even if they continue with the same, I don't think they will develop any problems ever. And if at all they develop, maybe they can take the help of a doctor again.
yes, I think visiting and us, the dermatologists, like Dr. Madhavi said, being the middlemen, I think we need to be well versed and we need to study how these treatments work and therefore guide the patient, because the patients are going to go do it anyway. So instead of treating their bad hair, might as well help them get better hair and healthy hair, right?
Very true.
Yeah.
So it was
Wonderful
it
being
was
here.
wonderful sharing with you all the tips, and thank you very much.
Thank you.
Sunil.
Good morning. I am Dr. Sunil Tolat from Pune, and I am lucky to have with me over here none other than Dr. Deepak Parekh, who is my mentor. He is my role model, and we both of us are interested in pediatric dermatology. And today we will be talking upon how to counsel or how to deal with parents who have come to us bringing their sick children for skin disease. So, Dr. Deepak, if a child comes to you, it's a very chronic disorder, I know. Most parents with children with atopic dermatitis are extremely anxious. On one side, it's a scenario where the child is itching badly and the parents are anxious, they want to ask you so many questions and you prescribe certain drugs to them. So the disease process, the atopic dermatitis, which we all know is a chronic thing, how do you go about dealing with such parents at your consultation in the beginning to explain them about the disease process?
Good morning, Sunil.
Yes.
It's a pleasure to be here. I fully agree with you that atopic dermatitis is one very frustrating disease to manage because it is chronic, because child cannot complain everything to the parents, parents are confused. Different messages come from the media, from relatives, from friends and from doctors. There are doctors who will tell them that don't worry, ye to chala jayega, and the disease does not go. Itching is so bad that child doesn't sleep, so parents can't sleep. So what I do in my practice is when I see an atopic child, I initially prescribe only antihistaminics, if required antibiotics, may ask for some investigation, but I take some time out and tell them about the disease.
Correct.
I tell them in a very, a very simplified language, which may not be absolutely scientific, but it gives out the message. So I tell them that your child is born with a tendency of a dry skin.
Correct.
Now this dry skin tends to get irritated with many different types of stimuli. Say for matter a simple cloth, a synthetic fabric will irritate the skin. The child's own sweat can irritate the skin.
Correct.
And when the child will get irritated and will itch, he will rash.
Correct.
So my suggestion to them is that you prevent the dryness of the skin, you prevent those triggers which bring out the itching. If you will take care of these two things, you will prevent the further itch and scratch cycle.
Correct. Correct.
So I stress quite a lot about moisturization,
Yes.
emoliation.
Correct.
I explain them that no emollient works once in a day or twice in a day. Depending upon the environment and the climate, you may have to moisturize it maybe even 6 times a day,
Right.
where it is very dry climatic condition. I explain them how to moisturize.
Correct.
Okay. You want me to explain that?
In very few words, if you can actually tell how you tell the parents to...
What I normally tell them is that to moisturize the child, first you need to put, if possible, child in the water. So just soak the child in the water. If child is already a grown-up child, you can't soak, or water is a scarcity,
Yes.
time is a problem, then I will say just sponge the skin.
Correct.
It helps in many ways. It puts a water layer, it cleans the skin, removes the dirt, dust,
Correct.
the sweat.
Yes. Yes.
And then you need minimum around, I would say, 30 ml of a moisturizer. If moisturizers, as they are costly, parents don't apply properly.
Yes.
So I at times ex tempore do mix it them with water and oil
Yes.
to save the cost and to make it more accessible.
Correct.
And I'll ask them to apply full body.
Yes. Yes. Yes.
Once they moisturize it, I will request them to cover with full sleeve cotton clothes.
Correct.
Now the advantage of full sleeve cotton clothes is it's a cotton, so it doesn't irritate.
Correct.
It absorbs the sweat,
Correct.
so sweat doesn't act as a trigger. Plus the environmental pollution don't sit on the skin.
Correct.
So these are the advantages.
There are certain parents who feel that applying oil before having bath is more useful. So I think what Dr. Deepak said, that the moisturizer will work only if moisture is already there in the skin and it will trap the moisture. So it is more valuable to apply a moisturizer after bath rather than applying before bath. So the same parents, once you are through the moisturizers, the moment you prescribe some medicines, all the parents are Google trained nowadays. they will come up with the question, अरे doctor ये तो steroid है, आप steroid क्यों दे रहे? As child we don't want to give our children steroids. So how do you handle this situation?
I agree. This is a very, very common problem nowadays in educated parents, those who Google it, those who have read about it. So my first concern is, rather than answering them, I ask them a question. I ask them that what are your concerns related to steroid? I must understand why they don't want steroid. Most of the time parent will come out and say, "Nahi, I was told that if I'll apply steroid, my child eczema will come out in asthma."
Correct, correct.
That is the first, impression, the statement they make. The second statement they make is, no, if I apply steroid, then my child will become steroid habituated and addicted. So I take those feedback to reply back them.
Correct.
Then I explain them that as far as it is concerned today, we have non-steroid drugs which works, but it works when the disease been brought under control.
Right.
And to bring it under control, you need steroid. And if steroids are used judiciously as per the prescription of the doctor, they don't have a side effect. It is over-treatment, overuse of steroid which gives the side effect. So I take them into confidence and then I prescribe steroids, and when I prescribe steroid, I make it a point to explain them how to apply steroid.
That's right. So there are certain skin conditions which are quite serious, and sometimes we have to give them medicines like methotrexate or maybe even cyclosporin, and to the lay person these medicines are anti-cancer medicines. So again, many parents are anxious. They will take the prescription, go home and come running back. Arey doctor, you have given us cancer medicine. Does my child have cancer? What does he have? You have not told us this is anti-cancer medicine. So how do you deal with this situation?
So this is very good question, and I tell you, this is actually every parent whom we prescribe immunosuppressants, they come and ask this question. So in my practice, what I normally do is, if I have to give an immunosuppressants, always we all will be doing some basic investigation. We will call them with the investigations to see if he is fit for the immunosuppressant or not. So when they come back with the report, I explain them that your child has such a widespread disease that it needs internal drugs. Then I will write down that the different drugs available for your child, starting with oral steroids, methotrexate, cyclosporin. Then I will explain them that steroid is not useful because of its side effects, long-term use, and getting used to and relapses. Then I will go to, when I come to me, say like a methotrexate, I tell them that all the drugs are used in not one disease but in multiple diseases. So like say a chloroquine, which is used in malaria and which is also used in rheumatoid arthritis. Same way this methotrexate is also used in many diseases, including in cancer. So if somebody tells you are taking anti-cancer drug, don't get upset. So what I do is I only inform them rather than they come to know from somebody else. Then I tell them that in cancer you take 2 gram in a day, whereas I will not give your child 2 gram in a lifetime.
Correct, correct.
Then I tell them that if we monitor it regularly, that there are no side effects. So I think it's informing them in advance, telling them all the facts,
Correct.
and hand-holding.
Yes.
Parents will take the medicine.
Yes, yes. So very good message, sir. According to you, this hand holding, you have reminded me of one thing. There are certain diseases like, for example, vitiligo, which has a great social stigma in India. Actually, as doctors, we know that this disease per se doesn't have any morbidity, but it is a very big thing to have vitiligo in Indian society. So once a child comes to you and you know for sure it is vitiligo after you have diagnosed it, how do you break the news to the parents? Ki, oh, this is vitiligo and you have to deal with it.
It's something where I think I have learned from experience. Maybe I am not 100%. I have seen parents, mother especially, starts crying in the clinic the moment you say code ahet or vitiligo. So my first take is I normally don't break the news on day one.
Correct.
What I do is I tell them I do wood slam. Even if I know clear-cut clinically vitiligo, I will still do the wood slam. So parents feel that he has seen to confirm it.
Yes.
That gets a confidence. Then I tell them it looks white, but I don't use the word vitiligo. Then I tell them, okay, do this test, because we need to normally in widespread vitiligo look for autoimmunity. So thyroid is always asked for. So I will just sensitize them that this is one of the possibility. When they bring the report, after the report, it may be normal or abnormal, I take that opportunity to break the second news, that this is a white patch. Now when I talk to them about white patch, I am very upfront and honestly, clearly tell them that yes, this is now a white patch of leukoderma. But there I don't end. I will go on and explain that leukoderma or white patch is not a medical problem. It's more of a cosmetic problem, more of a social problem. So this is how I talk to them कि जब बीमारी आपके बच्चे को नुकसान नहीं करती है तो ऐसी कोई भी दवाई नहीं करना जो बच्चों को नुकसान करे. If we use long-term steroid, side effects. There are people who use azathioprine with methotrexate. I am not one of them because I feel it gives limited response and you stop, it relapses. When it responds, parents creates an one type of an expectation, and when disease relapses, they go very bad mentally. So, in my practice, I inform and counsel them what care should be taken, so it doesn't spread like cobnerization, full sleeve clothes, outdoor play, socks and shoes. But I will give them a frank opinion that currently there is no guaranteed treatment anywhere on any pathy.
Getting a clue from that, there are certain parents who take their children to other pathies and then come back. For example, a child of vitiligo, maybe he goes to some Ayurvedic physician and he comes back to you with blisters and photosensitivity. So how do you deal with this? Do you disown the patient because he has gone to other pathy, or do you sympathize with him, or you try to explain to him how the pathies differ, or you stick to one pathy and don't take the other one? Many parents will ask you कि आप हमारा भी दवाई करेंगे, उनका भी दवाई करेंगे तो चलेगा क्या? So how do you deal with this?
Agreed. See, if I was a parent of a child who had, say, atopic or a vitiligo, I would also look for, because as a parent I want my child to look the best. Correct. And to have the best of the life. So I don't blame them, that is for sure. If they have gone somewhere and come back, I accept them. What I tell them is, you go anywhere, but just find out what it contains. I tell you, Sunil, in my practice I have seen Ayurvedic fellow using heavy metal, and lead and arsenic levels and blood have gone skyrocketing. Correct. And with side effects. So I show them those reports and then I tell them, okay, before you do any pathy, including allopathy, first run what it is, how much it will help you. If you still convinced, what things you should monitor, and then take a call. When it comes to question, if they will ask me कि आपकी दवाई के साथ में मैं homeopathy करूँ या नहीं, my answer to them is, I am educated only in my pathy. I don't know anything about homeopathy. I cannot say yes, I cannot say no. But I will tell you only one thing. Every pathy has side effects. So you understand what are the side effects of your doctor who is giving you homeopathy or Ayurvedic. Insists that he is giving you homeopathy or Ayurvedic, and many not, I would say 60% of them use allopathy.
Correct.
Though they are homeopath.
Yes.
And they develop side effects.
Correct.
So I will counsel them. I will not say no.
Right. So in the end, let us wind up by, there are certain diseases which cannot be cured. For example, many genetic diseases. So if you are working in a hospital and if you have you have been called to see a newborn baby and you know for sure that the child has got, let us say, ichthyosis. So all the parents are waiting, or if the child has got a big congenital melanocytic nevus. So how do you break that news to the relatives? The pediatrician will blame it on you. Pediatrician will say, Doctor Saab aayenge aur
Very common.
Yes.
I agree. It's the most common problem that we face. And the only option that is, you need to sit with the parents. You need to take first into confidence. So I don't talk to them about the disease or the child. I will talk something general. Try to connect with them. What he is doing, where he is working, what is his interest. It takes 2-3 minutes to break the ice. Then I will say, I saw your child. This is what his condition is. We will have to keep him under observation, how it evolves. On first day, I don't say it is non-curable.
Correct.
I will allow them to get gradually used to the condition and then give them the news.
Correct. So lastly, suppose there are certain allergic conditions in the skin which children suffer from. For example, urticaria, angioedema. and the child comes to you, you give the appropriate medicines, and after about 2 hours, the parents call you back. अभी तक कम नहीं हुआ डॉक्टर, अभी गोली लिया, अभी कम नहीं हुआ, अभी बढ़ते ही जा रहा है, बढ़ते ही जा रहा है. So how do you deal with this? You call them back to the clinic, or you give phone consultations, or you tell them go to the hospital and get admitted, I will be there.
I very strongly believe in no telephonic consultation, no WhatsApp consultation, because it has medico-legal ramifications. If such a situation, I always tell them report to the casualty. Come to the hospital, my RMO will see, if anything he will call me or I will go to the hospital. But I will not treat such incidences on telephone, for sure.
So I think that is all in our Derma talk, and thank you for inviting us.
Thank you Sunil.
Yes, we had a nice talk, and let's hope we can help the parents to get their sick children better. Thank you.
Thank you.
Thank you.
Okay.
Good morning. Good morning, everybody.
Good morning.
We are going to discuss the leprosy, and we have two experts. One is National Dr. Vikrant Sauji. He is a senior consultant dermatologist and vast experience in clinical dermatology. And Dr. Claudigo, he is the president of Brazilian Association of Leprosy. So I have a few questions about leprosy. Okay. So we will have discuss it. What do you think, whether the leprosy is eliminated? Is it really eliminated?
Well, if you look at the data, you see that we have problems in accepting elimination of leprosy as it is, less than one case per 10,000 inhabitants. What we believe is that we lose expertise along time just because leprosy was declared elimination in 2000. So it was declared eliminated in 2000. So people forget that leprosy still exists. Even students that are at the university, the professors, everybody, people that are on the fields. So leprosy doesn't exist anymore. When you say leprosy is eliminated, people think that doesn't exist anymore. And they stop to search for it. So we have many, many cases undiagnosed, especially on fields. Then this is necessary to check.
I think the basic problem with this is because it is eliminated, the control program is scrapped.
Yes.
And that is how we are suffering because the expertise is losing. It is managed by a general medical officer along with other program. So the expertise in the field of leprosy is probably going down, and there may be a problem. So we still need a lot of work to be done at least to eliminate leprosy.
So how you diagnose the cases? Means for early diagnosis, what you do, or what you do in doubtful cases?
Well, I don't know exactly why, but we decided, or somebody decided, or maybe the World Coordination of Leprosy decided that leprosy was a simple and easy disease, and that clinics was only clinics was good for deciding if you have a case or not, and there is no laboratory examination for leprosy. Even acid fast bacilli, at the slit skin smear, was gone. So there's nothing, there's just clinics. And in 21st century, to think about disease only decided only by clinics is something it's strange. We have many tools for other diseases, for HIV, for hepatitis, even for TB. We use PCR today. Why you are not using PCR to leprosy? There are many papers showing that PCR can improve the diagnosis. So if you use slit skin smear and acid fast bacilli, then you have a positivity in 15% of the patients, of all patients, 15%. But if you use PCR, you can go up to 80%. It's a huge difference. And what's the difference?
What are the
Just
samples
one,
used?
One you see the bacilli, and the other you check for the DNA, but the result is the same. The DNA is there.
What are the samples you use for PCR?
We use the same samples, it's just a slit skin smear, because we are doing research with that to compare both. So we use slit skin smear to compare acid fast bacilli and DNA by PCR. And the difference is huge, especially in early cases. Because there are many early cases that people sometimes say that we may possibly be misdiagnosing a case. But if you do qPCR in somebody that you clinically examined and you find clinical, even very faint clinical evidence that that person may have leprosy, and you do PCR and the PCR is positive, then you confirm the case. And you treat very early. You avoid disability and break the chain transmission. It's very good.
I think for TB, the PCR setup is there in every district hospital. It is done free of cost for TB. So same machinery is there. What you need is you just need one primer for leprosy. So if some leprosy research institute can create that, it will be very easy though. Every machinery is there. Just you put one primer and you can diagnose rifampicin resistance, you can diagnose leprosy. So it's done for TB, why not for leprosy?
Yeah, this is another thing that is important and interesting that was talked now.
Already it is for TB, so why not for leprosy?
Yeah, why not for leprosy? And more, you can check for resistance.
Yeah.
We are seeing the first years of resistance in leprosy. If we don't do nothing, we will have the same problem that TB has today in 10 or 20 years. Many people with leprosy where mycobacterial leprosy is resistant to one or more MDT drugs.
And what you say about treatment, I would rather say it's better to over-treat than under-treat.
Yes.
So in little doubtful cases, if you don't have resources, counsel the patient and better treat it. That's what my policy. Better to over-treat.
Sir, many a times orthopedician and neurologist send a patient with hypoesthesia and anesthesia. So we suspect it clinically as a pure neuritic absence. So how you approach these cases?
I think as a dermatologist, we don't investigate that much, at least a leprosy case. But I have seen with my neurologist friend, whenever I send them a case of neurotic leprosy for opinion, he advises no biopsy.
No biopsy.
And many times it is very conclusive. It tells you, even though you are clinically doubtful, the biopsy report tells us this is the leprosy, and that helps to diagnose many of the now neurotic leprosy early. But that is done only for pure sensory now. But it can be easily done, not a very big thing. So can be easily done in all doubtful cases.
Nerve biopsy.
Now
you are
biopsy,
taking on
yes.
nerve biopsy. That
Yes.
every case should be biopsy.
Yeah, in doubtful cases of now involvement.
What do you think?
Well, I believe we simplify it a lot. A disease that are not simple. So my question is, why we don't use the tools that we have today? We have electroneuromiography. We have ultrasound.
Yes.
So it's possible to see the thickness of the nerve using ultrasound. And ultrasound is not that difficult to have. So it's possible to use ultrasound
Yes.
to check for the thickness,
Thickness,
of the
thickness
nerve.
of the nerve.
We need to start to use that on leprosy because leprosy came to the 21st century and we stayed on the 20th century.
Yes.
So we need to come together with the tools that we have today.
Even-
Ultrasound, electroneuromyography, qPCR, we have to use that on leprosy.
Yeah, even FNSA tells about the type of nerve involved.
Yeah.
Yes, I think we need to investigate leprosy cases, which we usually don't do it. The
Yes.
facilities are available. Why not do it for leprosy patients?
Yes, and the thing is that very clear cases that we call classic cases, they have shrinked, but we have more cases like that, primary neuritic and the very this thing, and we have to find them. Otherwise, we are not going to check for all people, and it's not going down.
Vikrant sir, how do you treat the cases of lepromatous poles that the cases have a very high bacillary load? So do you treat it with only MDT? Do you modify MDT? NEPS, what are the modifications you do?
With high bacillary load, I think most of the private practitioners, if you discuss, they feel only MDT may not be adequate. So they need to modify, that's my personal opinion also. I use rifampicin more frequently. Like in US, they use rifampicin daily.
Yes, yes.
So
How
why
many-
not? Because it's not that costly drug. I mean, I think the basic aim of introducing this MDT is for the economics, that you use
Yes.
rifampicin less frequently because it was costly.
Yes.
It's no longer that costly. Patient can afford. So I do, my personal opinion, you can say, we should use rifampicin more frequently. So that will
How
lead
frequent?
to
How frequent?
most time for multibacilli patient, I use rifampicin and ofloxacin daily.
Daily.
For at least for 30 days, which may be more depending on the clinical response.
What is
But
your opinion, sir?
I use it definitely.
Yes, I agree with that. It's in Brazil you're using definitions that come from TB. So after 12 months, if you still have clinical disease that you believe the patient's not cured, so we call insufficient therapy, and we do 12 doses more. After 24 doses, if you still believe that the patient is not cured, you can talk about therapeutic failure. And after therapeutic failure, you need either to change the drugs
Yeah.
or to check for resistance in the bacteria. So we are doing this more. But I believe the situation that was told here, using rifampicin more frequently, daily, as they do in the US. In the US, they treat patients with rifampicin daily for 2 years. This is the standard therapeutics. And we use once a month. So it's a huge difference.
That means you added two bactericidal
Yes.
drugs,
Yeah, yeah,
rifampicin and oflox. You
Yeah,
use
that is what,
simultaneously in the
yes,
cases
yes,
who
and-
have a very high bacillary
Yes.
load or towards cases of a lepromatous.
Yes,
pool.
yes. But and I also add steroid many times along with this to prevent because of the bacterial killing and likely risk of exacerbating the lepra reaction. So I do combine this with steroid in most of the cases.
Yes, even I am using it for longer duration. So I start with two bactericidal drugs and simultaneously steroids. It definitely reduces the frequency of reactions.
Definitely, and rifampicin and ofloxacin are not very costly drug. Of all the second line of drug, maybe minocycline and clarithromycin are little costly, but oflox and rifampicin are at a very reasonable rate. So most of the patients, I think, won't find it that costly. So I think, in fact, I feel that initially for a high endemic area, in the control program, Indian control program, there was a one intensive phase where rifampicin was used more frequently, sometimes 3 weeks or 2 weeks. I think that need to be reintroduced, especially in the area where leprosy is still incidence is very high.
You know that there are some researchers defending, Dr. Joel Almeida, for example, defending that we treat BL and LL patients for longer times than 2 years. Because he believes that that patient may keep the infections going on in the community if we stop with 12 doses or 24 doses. So he's defending that we keep giving drugs for the patients. I believe we may find a way to put together this with maybe daily rifampicin or another drug like ofloxacin or minocycline that we use in Brazil. So we have to put this together and try to figure out what's the best for the patient.
I think the modification should have one thing, that minimum is WHO MDT, that you have to give.
Yes.
Whatever drug you use, you cannot say I am using 4 drugs, I will give only 2 months. No, you have to use WHO MDT.
Yes.
In addition, you can have, depending on your expertise and the availability of the drugs, you can go on adding other second line drug, or maybe rifampicin more frequently, or maybe you can add ofloxacin and minocycline.
That means you modify the MDT, and that depends on the bacillary load or the pool of the disease.
Yes.
Or if it is of the lepromatous pool, you do the modification. So when you how you suspect resistant cases clinically?
See, this is basically when you treat, and after 3 months or 6 months, at least you should see good improvement.
Yeah.
That is what we normally expect.
Yeah.
But sometimes you give the patient the treatment 3 months or 4 months, and patient doesn't observe any improvement, and then the patient also is find it very difficult to maintain the same treatment for a long time without improvement.
Do you think that the person who has completed his course, he is released from treatment, and still he is getting the ENLs, recurrent ENLs, could this be resistant?
At 1 year, that is after completion of the standard, if you clinically we decide, because smear will remain positive.
Yes.
So the study says maybe after a long time it will go. But if I see the smear and if I feel there are some live organism, my personal opinion, I do continue MDT for some more time.
Yes.
Maybe 6 months or more. Maybe I add rifampicin or ofloxacin. In that situation.
What is
I believe we have to be very careful with the use of prednisone and thalidomide for a long time. So if the patient is dependent of prednisone or of thalidomide, we need to recheck either if he's really cured or not. So we need to check for the Mycobacterial leprae if there is resistance or not. So we need to check more, because we have many people now using prednisone for long periods because of reactions or neuritis, and we do not recheck them. We just keep giving them prednisone or giving them thalidomide, and we need to check if there is any other possibility for them.
How you treat the resistant cases?
Well, the resistant cases, we have in the Brazilian government make available ofloxacin and minocycline. So the patient, it's possible for the patient to access, and it's possible for the doctor to ask those 2 drugs from the government. So yes, it's possible to change one of the drugs, rifampicin or dapsone, because we don't know nothing about resistance to clofazimine. So, but rifampicin or dapsone, if you check for resistance and there is something, then you can change and use ofloxacin or minocycline or even clarithromycin. And we are using also, not only me, but other groups in Brazil, we are using moxifloxacin. There's a very good drug for TB, and it's a bactericidal drug, so we are starting to do that, and the results are good, but I think we believe a try on that.
I think that there is no definite guidelines, WHO guidelines, what to do for a resistant cases, and it depends on the individual experiences. But what is logically, there are other drugs, second line drug, like oflox, minocycline, clarithromycin. So this we have to use, and I think for leprosy, no treatment is short term. I mean, it takes at least few months. So maybe for 6 months at least further,
Yeah,
we
even
need to
even
this
the
is-
expert group has mentioned it, use it for 24 months, and the first 6 months is a intensive
Yes.
phase in which the rifampicin is given daily,
Yes.
and the other drugs are continued for next 18 months.
Yes, I think it requires definitely longer treatment.
Definitely longer treatment
more
for the-
drugs, MDT, including more drugs for little longer duration. But I think that is basically clinical judgment we take. We see clinically whether the patient is improving or whether the still inflammatory, still some induration is there.
Tell me something about childhood leprosies.
Childhoods. Well, we go to the houses of the patients. I live in Amazon, and I go to the house of the patients and examine all the families. And the families sometimes have 10 members, 15 members, 20 members living sometimes in the same house. So we have to check for everybody. And we are doing slit skin smear for PCR, even in contacts.
Contacts, healthy
Yes.
contacts, healthy
Yes, health contacts. I examine them, and if I find something, we define the case there and start treatment. But we collect slit skin smear and go to the laboratory and check for PCR. So in 80% of the cases, we have a positivity in PCR. So PCR is good. It's good
PCR
for
is good.
early diagnosis. And even those contacts that I examined can't find nothing, 20% are positive for PCR. So we have to follow those 20% because I believe
They are the
they
source.
they are the sources,
They are the
and
source.
they may be clinically evident in the future.
Yeah.
Yes.
That means the PCR is definitely helpful.
Yeah, this time that we live now, I think PCR is definitely is a good tool.
So, Vikrant sir, how frequently you see the childhood cases?
Childhood we do see, but not that frequently.
Not
we do
frequent.
see, not
That-
very frequent. So maybe because it's a long incubating phase, so maybe it's evident after a few years.
Yeah, might be.
So you know it's completely different because I work also at the reference. So if I stay on the reference, well, I see advanced cases even in children with grade 2 disability and these things. So these cases are the cases that come to the reference. But when you go to the house of the patient, you see many early cases. It's completely different. And it's difficult. It's not easy. It's not an easy task that somebody in the field with little training can do. No, it's something that it's more difficult to diagnose.
For which I think the field work folks should be there.
Yeah.
Yeah,
The
field
field
work
quality
should be
control-
there by the experts.
Yeah.
Yes.
By the experts.
By the
Yes.
experts.
Yeah.
Yes.
Yes.
So, how you treat the cases of steroid dependent TNLs? Recurrent TNLs?
Thalidomide nowadays is a good option.
Yeah,
So I do use thalidomide. Unfortunately, is little costly.
costly.
So it's available at many of the government centers, may be free, but for practitioner also, we do get sometimes at a subsidized rate, but still costly. But I think it's worth it because it otherwise severe type 2 leprosy patient doesn't go to work, is all the time bedridden,
Recurrent
sleeping. So
steroid.
at least with this drug, patient can manage to go for his
How
work.
you give thalidomide?
I usually start at least first few weeks steroid and I introduce thalidomide. Thalidomide, because of the cost, I tend to use it little, I mean
Lower
not very high
doses,
dose, so
lower
maybe
doses.
100 BD.
Or 100 TD or
Then many times along with steroid 100 BD in many of the patient is adequate, and then over a period of time gradually taper off.
You stop the steroids and continue
yes,
the
yes,
thalidomide,
yes,
or you stop both the things.
No, steroid I stop, and thalidomide also, because there's a one important thing is the cost constraint. So
Cost
we have to use for a minimum possible duration. But I think with thalidomide, most of the type 2 leper reactions are well under control.
What is your opinion?
Yeah, for thalidomide, usually for most of the patients, I start with 200 milligrams per day.
200 milligrams.
200 milligrams per day, and I usually do 30 days. And after 30 days, I diminish to 100. And usually in 2 months, you can control the patients. Most of the patients can be controlled in 2 months. And then we try to remove. If this guy starts to have again and again, you have to check for other things like the resistance, as I told you before.
Yes,
So,
yes.
yes.
clinically suspected resistant
Clinically
cases are
suspect
generally
resistant
steroid
cases,
dependent
if
recurrent
steroid
AML.
dependent and thalidomide dependent, those guys need to be tested. And we don't know all the places of resistance on mycobacterium leprae. There are recent papers showing that probably other parts of the genome of the mycobacterium leprae is responsible also for those cases for resistance, but we don't know yet. So we need to clinically define that because it's necessary for the patient. This is very important for the clinician.
What is the role of immunosuppressives in recurrent ENLs, in steroid dependent, thalidomide dependent, recurrent
we
ENLs?
have-
What is the?
Well, we have some experience with chronic neuritis using cyclosporine.
Yes.
Yeah, we did cyclosporine for chronic neuritis in some patients, but some of those patients, after a while, I had to treat them again. So showing again that the bacilli was there yet. And at that time, if I had the experience that I have now, maybe I would treat them before that. So yes.
What is your experience with
I think
cancer?
there are reports that azathioprine was effective in some cases and
Methotrexate
methotrexate was
is a-
found to be effective. But what I have found, no single immunosuppressant is consistently effective in all the cases.
Yes.
Yeah,
So
depending.
Yeah, that's true.
I feel steroid and thalidomide are usually my preferred drugs nowadays.
And some are very expensive. Cyclosporine is very expensive.
Yeah.
Yes, expensive is the
Yes.
issue. In my institute, I have used IV cyclophosphamide. I give a single pulse in these cases. So I tried it in around 20 patients, and I found that the effectivity is around 60%. That means
Okay.
60% patients who are on the steroid dependent recurrent ENLs after cyclophosphamide, they are not getting the ENLs.
Okay.
But that is good. But only thing I feel while using methotrexate, we have to be very careful because we are already using dapsone,
Yes.
Yes.
which
Yes.
which may have a problem with methotrexate.
Yes.
So I think if at all I did try methotrexate in few patients, but then I discontinued dapsone.
Yes, still reports of biologicals are also there.
Maybe I think
Not-
beyond
I
the reach
don't
of
have
a
any- I don't-
leprosy patient, definitely.
Nice talking, Claudio sir. Nice talking, Vikrant
Yes.
sir. Thank you, both of you.
Thank you very much.
Thank you very much.
I'll have a look at that.
Yeah, you have to look at that. Because this city's traffic is
From Westin to the...
From Westin to the airport will take you an hour and 20 minutes.
So you start.
Yeah, I'll start the interview. Good morning. We are collected here at the Pune Convention Center for the Dermacon India. Dermacon is a national conference of dermatologists in India. So we just thought we'll take an aside and convey and connect with general dermatologists in India and the lay public overall through different channels on specific topics, and the topic that we are going to talk about is psoriasis. I have with me a very distinguished professor, Professor Lars Iversen from the University of Aarhus in Denmark, and I am Dr. Muralidhar Rajagopalan, and I am from Chennai in India. Both of us got to know each other and got to work with each other because we work for the International Psoriasis Council. And yes, you guessed it right, we would like to discuss something on psoriasis. Psoriasis is a common problem, and most people are a bit scared of psoriasis because they don't like that word itself. But we have tried to demystify it for you, and we'll try to do this by means of a chat. Is that okay, Dr. Iversen?
It's fine.
Great.
It's fine.
Why don't we just talk about, if you can just give a half a minute or a few seconds on what you would classify as psoriasis in a layman's term for them, for the audience, sir.
Psoriasis is in general, you know it as well as me, it's in general considered a skin disease.
Yeah.
But I think over the last 2 decades or so, we have learned that it's even more than a skin disease, and that's what we discuss at meetings like this and international meetings in general.
Yes.
That we have learned so much more about psoriasis.
Yeah.
In the past, it was considered a skin disease, a disease of the cells in the skin, but over the years we have learned that it also affects other things. We know that psoriatic arthritis, joint disease, is part of the disease spectrum. And we've also learned that psoriasis, or having psoriasis, is sometimes associated with other morbidities like cardiovascular disease, depression, among others. So psoriasis should be considered as a disease more than simply a skin disease, but a disease that affects the entire body.
So what we are trying to convey here is that psoriasis, though this is going to be seen by dermatologists everywhere, there will be people who are not dermatologists, and psoriasis, even the term refers to something to do with the skin, but it is much more than skin deep. It is a reflection of something that is happening in the body, and there is a basic defect in the immune system of the body which triggers it to work against the skin, and that stimulates psoriasis. And as Professor Iversen was just saying, psoriasis need not necessarily just be limited to the skin. We should look out for effects on the joints, on the heart, on the liver, and even diabetes and obesity. These are very important non-communicable diseases, and As you all know, non-communicable diseases are right on the rise in our country and the world over. How is it in your country, sir, as far as the non-communicable diseases are concerned, the burden of such kind of non-communicable diseases on the population?
We are becoming more aware of treating not only the skin symptoms in psoriasis, but treating the entire disease or symptoms that you have with this disease. So we are moving in the direction of taking a multidisciplinary approach to these patients. And in my clinic, we now have a multidisciplinary setting where we have rheumatologists, gastroenterologists, because we also know that psoriasis is associated with Crohn's disease, some of the inflammatory bowel diseases. We even have a psychologist, and as you mentioned, increased body weight is part of the disease spectrum, or at least you see it more often in psoriasis patients. So we have a dietitian as well in the clinic. So we think this multidisciplinary approach is becoming more and more important with non-communicable diseases in general, but in psoriasis in particular.
I think in India, many of us do follow, when we treat psoriasis, many dermatologists treat psoriasis one-on-one, but adopting a multidisciplinary approach to treating psoriasis, I think, is going to be the order of the day. And sooner or later, we'll have to realize that as a patient, if you come to see a dermatologist and he orders a few tests that don't seem to be connected to your skin, do not be surprised, because he's actually looking for something that is happening inside your body. And if he's going to look at something that's happening in your body, it might make a very big difference between life and death. One important point which Professor Iverson mentioned was having a psychologist in the team, because psoriasis is a very major cause of depression, and it is ranked next only to cancer, if I'm not wrong, as a leading cause of depression and attempted suicide also. We do not mean to frighten anybody about this, but we only want to stress that you need to take a very holistic approach towards treatment of psoriasis. You treat the individual rather than just the skin. So what do you think, sir, would be is there an ideal way to treat psoriasis? Because once we have said this, people are going to ask us, is there an ideal way to treat psoriasis?
And
can we just
to that I should say, I don't think there's one way to treat psoriasis.
Right.
We really have to take an individual approach to these patients, because psoriasis in one patient is certainly not the same as in the next patient. Psoriasis has so many phases.
Yes.
So we have to have a personalized and individual approach to this. And we have good treatment options for the skin symptoms, but if you look at it with the comorbidities that we have discussed, we know that some of them has some comorbidities, not all of them, but they have some comorbidities. The other patients have another combination of comorbidities or morbidities associated to psoriasis. So we have to take a very individualized approach, but we have excellent tools to treat the skin. And like in most countries, I think that starting the first initial treatment to any psoriasis patient will be topical treatment. Topical treatment is good for many patients, and that's enough for many patients to gain good control, and that includes the corticosteroids, but also in many countries the vitamin D analogs can be used. And then UV treatment is an option as well. So these are the topical treatment options we have in our armamentarium. I guess it's the same in your country.
Yeah, it's very much the same. In our country, the access to external creams and topical treatments, light therapy or phototherapy, vitamin D analogs is very much being used over here in those patients who qualify for it. But as you rightly said, we need to personalize the treatment for the patient. So we are in an age of precision medicine where we are able to target.
And that's also because we now start understanding. We know that psoriasis runs in families. So we know that the genes, the genes that you get from your parents are important. But we know that this is not a monogenic disease. We know, I guess, around 100 genes or so that are associated to psoriasis. So definitely, as you said, precision medicine. In the future, we will probably be able to identify what will be the disease course of a particular patient, and also what will be the right treatment to this particular patient, because then we can analyze what proteins are expressed, what genes are altered in this particular patient. So this is the way, the direction we are moving into, but we are not, certainly not there yet.
No, it's good that you brought this up, because a lot of patients ask me, is this disease genetic and can I inherit it? Now the point we need to re-emphasize here is that it is not monogenic. By monogenic, it's not one single gene. There are more than 100 genes which are looking at different aspects in the causation of psoriasis. So when we start ultimately targeting psoriasis, we'll need to start looking at better methods of deciding which are the genes that are more active and which are the ones that are the driving force behind psoriasis in a particular patient. So that could probably be the link between the skin involvement, the joint involvement, or the involvement of other organs.
Exactly.
What do you feel, sir?
I very much agree on that, because there is this link, but the link is probably different from person to person, because it is, as you said, it's not one single gene that causes everything. It's the combination, and the combination can be, it may be like 4 or 5 or even 6 out of these 100 genes that are associated with psoriasis that are present in one person, and it's the combination that seems to play a role there.
So when we know that there is a combination of genes and psoriasis can affect your joints, it can affect other organs in the body, my personal goal is to limit disability in a patient of psoriasis and to keep the disease under control for as long as I can in the current scenario. How is the approach different in Denmark and in Europe and in the developed countries?
Not very much, in fact, because I think what we're discussing at international meetings, again, a meeting like this, but also if you go to Europe or US, what we're discussing is that if we treat more aggressively, if we treat very early on in the disease course, can we avoid the development of some of these associated diseases that we see with psoriasis? And there's no clear answer of that yet. It's possible that if we treat aggressively, we can minimize the risk of getting cardiovascular diseases, but it's not yet proven. So we don't know exactly how it is. So I very much agree, and that's the same approach we have. We have to minimize the disability of the patient. So the patient's quality of life is extremely important, and that's also something that we monitor when we treat our patient in my country.
One very important difference between what is happening in your country and in India is that the quality of life and the economic viability of an individual is measured in your country, if I'm not wrong.
You're perfectly right. And in fact, when we talk about some of the very expensive medication, which you have to, so to say, qualify for, I think what I've seen at this meeting or heard at this meeting, you have to reach a certain disease severity, which is measured with something we call PASI or BSA. This is how you can qualify. That's exactly the same in my country. But what we add on top of that is that if you have a high burden on your quality of life, this is also a way you can qualify. And that's maybe where we differ between my country and India.
The only reason why that difference is there is because of the cost of some of the interventions in India. Whereas in many countries in the West, it is sponsored by the state and insurance plays a very big role. In India, insurance and state support is minimal, to say. Though we have a lot of states which do provide first class and state-of-the-art medication to the patients, but we haven't got there yet. And it's very important to personalize the care for that particular patient, and that's where the cost-benefit analysis comes in.
And that's what we have in my country. That's provided by the government. So so if the patient fulfill certain criteria, it's not that you can pick it on and say, I want this medication, but if you fulfill certain criteria, yes, then you can qualify for the medication, and it's provided for free by the government. But it's a huge economic burden.
You think it would be fair to say that if we counsel our patients well on day one when they come to us for treatment, we would be conquering half the job?
I think so, because I think it's so important to do that.
Because the patient needs to know what is going to be the disease pathway. And having one single patch today need not mean one single patch for the rest of your life.
Exactly.
So it could go in a parabola, it could go in multiple ways of
It can,
transition
certainly.
over a period of time.
You're not able to predict that.
You can't predict the course of the
Exactly.
disease. So
Exactly.
the counseling is important. The options available for treatment are important.
Yeah.
The cost of the options in terms of direct costs and the cost of the options in terms of probable side effects and what is the type of monitoring you need to do are also important.
Exactly.
So I think in our counseling, it has to be made very clear to the patients that the drugs are good, but this is the rider for the drugs, and this is why we're giving you the drug.
Yeah.
Now, that's what I do for many of my patients. So how do you ensure compliance in developed countries, sir? Because in India, compliance is a problem.
It's the same everywhere. It's a global problem. It's not only in India. It's a
Yeah.
global problem.
Right.
But I think you are perfectly right. You have to sit down, discuss with your patient, explain your patient what is psoriasis, why do we choose this treatment, how do you use it. It's not just writing a prescription and then the patient has to deal with it by themselves, because then you will have no compliance. That's for certain. But that's not a problem in India only. It's most likely a problem in India, but it's certainly also a problem in Denmark. So we have to spend time with our patients, explaining them the disease, how to treat it, how to use the medication.
You know, about 10 years ago, I wrote a long series of small snippets on psoriasis for dermatologists. And somebody asked me, where would psoriasis be in 2014, in 2040, as far as treatment is concerned? What's your take on that, sir?
One of the
I honestly didn't have an answer.
No, I don't have an answer, but it's always intriguing to speculate. And I think one of the discussions that we have nowadays is, can we actually intervene on this disease course that we have discussed, that the patient can go into if we treat in a special way very early on in the disease. This is what we are researching into nowadays, and maybe that will be something that we can be more certain about in 2040.
That's great to know that there is some hope for patients with psoriasis, and especially with good counseling and good drugs and good methods of assessing the risk. Probably in future we can even chart out a course of how the disease is going to progress for the patients, probably in future. I think that's what you're looking at in future now.
Yeah.
I think with that, I think it's important to understand that psoriasis is not something you should get scared of, but you should understand better. And there is no better a person than your dermatologist who has specialized in psoriasis, who can take you through the journey of understanding and treatment of psoriasis. I really would like to thank Dr. Lars Iversen, who's come all the way here from Denmark. In fact, it's the second time he has come here at my request, and I'm very grateful that you came down and you sat down for this short impromptu interview to make things very clear to a lot of our patients and dermatologists in the country. Thank you very much, sir.
Thank you.
Have a great day.
Thank you.
Thank you.
Hi friends, I'm Dr. Abhay Talati, cosmetic dermatologist practicing in Mumbai. And at Derma TV, today we are going to have a very nice interaction with eminent doctors from USA, Dr. George and Dr. Christopher.
Hello, so I'm Christopher Zachary. I'm professor and chair of the Department of Dermatology at the University of California, Irvine. And on my right,
yes, I'm George Haruza. I'm the president of the American Academy of Dermatology, an adjunct professor of dermatology and otolaryngology in St. Louis, Missouri. And I'm really happy and looking forward to DermaCon this year.
Yeah.
So officially welcome to Pune and India.
Thank you.
So let's get ahead with the discussion. Today we are talking on something as aesthetic dermatology in resource poor setting. So actually in India it's on the rise that we are doing a lot of aesthetic treatments now, but the affordability on the part of patients as well as abilities to have multiple resources in the clinic is limited. And I think probably your inputs from your experience about aesthetic dermatology in such settings can actually be very valuable.
Sure.
Sure. Well, from our point of view, you know, when they leave the residency program after 3 years, they're pretty much trained in general dermatology, surgery, lasers, cosmetics. But at the end of the day, they have to go out into a private practice where they won't have all these resources. So actually, we have exactly the same situation back home, where you have to decide what you can afford, how effective these devices are going to be, and indeed what's going to make a difference for you to develop a successful practice.
Well, certainly the key thing is in resource poor countries is who's going to buy a $100,000, $150,000 device. Yes. It is just not practical, because then how much you have to charge, you really can't make that work. So there are many techniques available which don't require that big capital investment. So what we use in our office, a lot of surgical techniques where you just need some minor instruments to be able to improve aesthetic outcomes. And on top of it, in India, you have patients with skin of color. And so if you use devices like lasers, often you end up with pigmentation, with problems with pigment darkening of the skin or lightening of the skin after procedure. So what I find that's very helpful is using surgical techniques such as subcision, where you actually, if you have someone with acne scars, instead of doing something from the top, you actually go in underneath using special kind of needle called a no-core needle, and then you can go underneath and just break up that scar, loosening it up. And the needle costs a few cents, and of course local anesthetic, and you can achieve some nice improvement, and you have no risk of hyperpigmentation or darkening of the skin. So that's one technique that I find very helpful for acne. It can even be used for certain wrinkles as well, especially if you do combine it with filler materials. So if you do the subcision and then you put some filler material in there, I know that gets a little bit more expensive, but still not as much as some of those big expensive devices. And then you, by placing those in there, you can get a longer-term improvement in the appearance on the surface.
So while we're talking about acne scarring and relatively inexpensive things, all the rage these days is microneedling. And microneedling can actually achieve something, but to get a really good result, you really need to add radiofrequency to microneedling so that you can actually quite specifically put an area of injury at different depths down to 2 millimeters into the skin, where you will create new collagen, new elastin. And I think the research demonstrates that you can improve acne scarring, but it does pretty much nothing for skin tightening unless you use the radiofrequency. So microdermabrasion, you will see it out here in the technical exhibits. People will talk about microneedling as though it does everything, but actually I think we must be aware of the fact that it has limited benefits.
Right, definitely. So we are doing a lot of subcision, and actually subcision is one of the common modalities which we perform in our settings also for particularly acne scars. and we are using Derma rollers as well, which is manual micro needling, though the results may not be as good as the machines, but definitely if you have no resources, it's good to begin with. Then probably other challenges which we face is that, when we want to select the device in our resource poor settings, what we are doing is that we are trying to get the devices which are multi-utility. So you look at an IPL systems, which are probably less costlier as compared to that of other sophisticated laser machines, but they bring in a lot of utility. So we can use it for acne, we can use it for rosacea, we can use it for skin rejuvenation, some brightening photofacials. So we are trying to utilize like multiple indications with one single device.
And I'd agree with you. I'd agree with you with IPL can do many things. But I think one of the most common lawsuits in the United States is the use of the intense pulse light, particularly in skin of color. When, particularly if you turn the energy up and don't have enough cooling, you can cause a lot of problems. So have you experienced that here?
So skin of color definitely needs a different type of parameters and treatments as compared to probably a Fitzpatrick 1 and 2 type skin. So you have to adopt to your type of patients. So the energy levels are low, the filters are probably different. So we have a dark skin filter for hair reduction if you are using IPL for the hair reduction. So definitely the laser parameters have to monitor and change probably based on the treatment which you are offering to different patients. So we have skin types from 3 to probably 5.
Yeah.
So even the parameters would differ between type 3 to type 5. We are using a lot of chemical peels for skin rejuvenation and brightening. That's also something which comes at reasonably lesser price, and it's easy to perform in clinics, doesn't take a lot of patient time. Patients have to be guided about how to take care of your skin, because again, your skin is going to exfoliate. There is a chance of hyperpigmentation of the skin. But if you have exact understanding of what type of skin you're treating it with what type of solution, then definitely the results are rewarding.
So moving from acne to hair removal, I think our experience would be that use of the long pulse 1064 is much safer than the diode 810 or the Alexandrite 755. Of course. Or certainly than the ruby. Of course, the ruby laser was the original laser that was used. It was so effective by Rox Anderson and the team at Wellman, who did so much in terms of laser development. So 1064, for those of you out there watching this show who want to do hair removal, 1064 is a lot safer than some of the other lasers.
Right. I mean, the 1064 is optimal, and you can get that on a number of devices where you mentioned the sort of a platform device, where you have one base unit and then you attach a number of attachments. So you have a 1064. You can have the IPL, you can have some other fractionated heads on that too, so you can get these multiple ones. However, realize that when you get a multiple head device, once you combine all the different heads, you could still be at a very high price point. So it gets challenging because each additional, they said, oh yeah, we can get you that, it's another $30,000. And this one, oh sure, another $30,000. And then the service contract, of course, will be another 10 or 20. So it still can get quite expensive. You mentioned chemical peels, and I think for patients with skin of color, it's an area you've got to be really careful. And so you, of course, are the expert, I think, in that area. I would think that most of the time you would be using things such as glycolic acid peels, superficial peels, and multiple sessions. Be gentle. You don't want to be using like sort of TCA or even phenol. Certainly would never be something you'd want to use in India. So using those superficial peels is key, and then I forgot what my last comment was.
So the other point is when we get down to things that work, in terms of cosmeceuticals, this is a multi-billion-dollar industry out there, and most of the cosmeceuticals do nothing for you at all. I think there are about 5 things that work. The retinol obviously works. I think sunblock works. And moisturizers, I think, work. I think the hydroquinone works. And maybe vitamin C and other antioxidants. But beyond that, I'm not sure that any of the cosmeceuticals work. What is your experience?
So if you look at using a cosmeceutical, we are using particularly the retinol, which is useful for anti-aging, to an extent for young seborrheic skin also, to reduce the oiliness of the skin. For pigmentation, definitely the first choice of most of the dermatologists here, including me, is hydroquinone.
Yeah.
So we are using hydroquinone to reduce the pigmentation like melasma and some other acquired melanosis for about say first 4 to 6 weeks, and then we are moving to the other depigmenting agents. Moisturizers are helpful, though in some of the places where the humidity is very high, the amount of the moisturizer which you use or the type of the moisturizer which you select is going to be a little different as compared to the areas where it's on a more on a drier side.
Right.
Sunblock is essential. We are a tropical country, so we have a lot of sun exposure.
Yeah.
We are definitely using sunblocks.
Yeah.
My understanding, or I would like to know one more thing, is that suppose we are trying to look at anti-aging treatments now.
Yes. Yeah.
How do we use it, like resource poor setting, to have the effective anti-aging treatment according to you?
George, what do you do?
Well, Chris, you kind of mentioned some of the most effective ones, and so retinols I think are relatively inexpensive, so those should be easy. Hydroquinones are not for aging, but because of the pigment issues here, I think that's a key part of any procedure. The antioxidants tend to get more expensive, and I'm actually not sure if they've been shown to do much of anything.
Right.
Because the problem with, for example, with vitamin C is that as soon as it gets exposed to oxygen, to air, it oxidizes and becomes inactive. So I don't even know how we're getting activity there. And the science certainly is not there to support that. But I think actually the best anti-aging agent out there is good sunscreen.
Yes.
I understand that in India, of course, skin of color means that you don't get the sunburn.
Yes.
However, you still get aging from the sun. So you want to have a broad spectrum sunscreen. The important part is it's going to cover UVA, ultraviolet A, because that's I think what leads to the elastosis and the damage in the dermis that causes wrinkling. So
Yes.
I'd say good sunblock is the key thing to use, and the ones to use in this setting probably would be, there's a whole controversy about chemical versus physical sunscreens. Yes. But with skin of color, the physical sunscreens, the problem is when you put it on, it kind of looks white, not very attractive, so you got to usually go with the chemical. And there is no evidence to suggest that those are in any way unsafe, even though there's been a lot in the press about it.
Big controversy in the US
Big controversy
right now.
in the US right now.
So we have actually tinted sunscreens as well, which suit your skin type. So people who are a little darker skin has a little darker or a tinted shade so that you can match your shade.
Yeah,
perfect.
Because it has to be cosmetically acceptable.
Yes.
Otherwise people don't use it even after you recommend.
So we've covered a lot of the basics here. If you're going to use something which is a bit more technically superior, I think the fractionated lasers have really made a big difference, particularly the 1927 fractionated laser, thulium. It's quite useful, and also in patients of color, skin of color. And I find that you get very little in the way of post-inflammatory hyperpigmentation, but you can induce PIH with really anything, right?
Of course.
And so, hey, you know, I think if you've got the interest and you've got the market out there, some of the fractionated devices can be really good, not only for pigmentation, but also for anti-aging, for collagen development, new elastin formation.
Well, I think it's really important to, as you mentioned, non-ablative fractionated lasers, and when you use them, the settings are going to be different than what we would be using in the US, which usually means just lower density. So you're going to have lower density, and then of the spots, and you do more treatments to get the same result.
Yeah, I think it's a very important point. The density issue is key.
Yes.
Keep it down. You can always do another treatment.
Right, yeah. So one more understanding which I want to bring out here is that a lot of people are not able to buy the lasers in the clinics. If you have your own setup, if you don't go to hospital, you have to buy all the machines, then it's difficult to acquire all the machines. Do you think that injectables have a role? Because what we realize is that some indications like maybe few wrinkle reduction with botulinum toxin, dermal fillers, even though the resources, like you have technical skill, but you are not willing to or able to buy the whole system at one go. Yeah. Probably as a building block, you're starting anti-aging with probably reversal of wrinkles and maybe few hyaluronic acid syringes, and then enter to the device system.
I mean, I think that's exactly it. Fillers and the neurotoxins are not just a great way to enter the process, but you again don't have the problems with hyperpigmentation issues. because this goes into the skin, and and it's a very quick result. So patients love it. I mean, if you do a neurotoxin, you inject the crow's feet, and they disappear. I mean, that's magical in 2 or 3 days. And the fillers, same thing. So I would say that's certainly where you want to start before you spend $100,000 on a device.
So George, have you ever had any Botox?
I will admit I've never had a filler, but I have had Botox. My problem with Botox for me is that I really don't like to get shots. So when we do it in my office, it's about one every 1 or 2 years, and they've got to put topical numbing cream on me, and I'm still like, everybody says it's a nightmare to give it to me. So yes, I have had it, but it's quite infrequent.
So that's important in terms of pain and the fear that patients have. And we always use a 32 gauge needle, which is in many people's almost imperceptible. But my friend George here is a sensitive chap.
Well, men are just much worse than women, I tell you that.
Let me tell you a good trick though, for your patients who know that they're going to faint, that they have the vasovagal attack. It's always a good idea just beforehand to give them a little atropine, 0.5 milligrams, subcutaneously or intramuscularly. Wait for 10 minutes and they won't faint. So it's a good little trick.
I think that's cute, even though I just have patients always lying down when I do these things.
Lying down,
that's really important,
So we are also using 31 gauge needles for Botox.
Using what, sorry?
31 gauge needles,
31,
which are for any botulinum toxin injections.
Yeah.
And I feel considering the Indian perspective, probably in resource poor setting, we start with microdermabrasions, derma rollers, chemical peels, add on to some injectables, and as you gradually upgrade your practice, your patients also feel that you are doing good work. You install machines, and then it becomes a resource-rich setup.
So and then body shaping is all the rage these days, and obviously body shaping, body contouring is going to be something that's going to cost some money. But the thing I would say, the first thing I say to all my patients is diet and exercise. I could do with that myself, of course, according to my wife. So diet and exercise, and then remember that it's not liposuction. It's not going to give you the same results, and you don't get rid of the fat. If you use cool sculpting, it's going to redeposit that same fat somewhere else. But the whole body contouring business is very big in the States. Is it big here?
It is getting bigger. But in resource poor setting, it's not something which will get into that.
Very good.
So it's great interacting with you, Dr. George and Christopher. Pleasure talking to you.
Thank you very much indeed. We've appreciated it. Thank you.
I'll talk about isotret. Yeah, but you better you elaborate on that. I'll elaborate on isotret. Let's start on oral therapy of acne. Because see, we have laws on isotret which is not followed here. Oral isotret and insulin you can talk. And I'll ask you about insulin. With what, acne, and we start oral therapy. And then Sangeeta Vilaskar, who is the head of Medical R&D Kaya India.
And it's my pleasure to introduce my dearest friend, Dr. Minal Patwardhan Andrade, who heads a very, very successful dermatological practice in Dubai and Sharjah in the UAE.
And we are partners with Kaya now, so
Yeah.
it bonds us even closer.
Yes. And we are going to do a little snippet on acne. And as we all know, acne is really one of the commonest conditions worldwide. Virtually 50% of the population is affected by acne at some point in their lives or the other. And we know that in youngsters with acne, it provides a very, very deep emotional and psychological impact and a lot of concern to the patients. And I think it's a good thought to just recap a few important points related to the management, approach and management to acne. So, in this short little snippet, we will concentrate more on the oral and the devices which are used to manage acne. And why don't I start off by asking Meenal what is her opinion and her way of managing with retinoids.
I love giving patients oral isotretinoin because ultimately I have realized that whatever the cause of acne, be it hormonal or anything, it is ultimately the stickiness of the cells of the follicle, and even it causes occlusion. So we need to bring out the microcomedones and the comedones, and easiest way is to use oral isotretinoin. Now patients have a fear of oral isotretinoin. Most of them tell us, oh my God, it's a very dangerous drug. Just in short, for the dermatologists here, because where we practice, we have very strict rules on prescribing oral isotretinoin. We explain to the patient that it is a chemical form of vitamin A. What it causes is a regularized keratinization, and it takes care of the comedones, the acne, as well as it starts healing the scars. You face a dryness not because of dehydration but because of keratinization of the skin, and it is the stratum corneum which causes that dryness. I always tell my patients, treat your entire body because you're taking it systemically with love, care and affection. That means lots of moisturizing, 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 use of sun protection very strictly, and I tell them to avoid any form of scrubbing, heat, local, waxing, going for steam, sauna during this treatment. Preferably I tell them to avoid swimming for a little while. Oral isotretinoin can be combined with hormonal treatments as well as with glucophage and metformin, as we know about insulin resistance, which Dr. Sangeeta is going to speak on. Just one small point, we are very, very careful when we treat married patients because unlike the normal myth, it is only for 1 month post the oral tretinoin treatment that we need to avoid pregnancy. The patients are supposed to avoid pregnancy strictly during the treatment and for 1 month after stopping, because in 3 weeks the drug is washed out of the body. So you need to emphasize this. You need to take a consent of the husband and the wife in case of married people, or make sure that they are on oral contraception because that is the safest, or a copper T or some intrauterine device which will prevent pregnancy 100%. I'd like to ask Sangeeta, how do they manage with the insulin resistance, because we find it very, very common, and in our part of the world we prefer to refer the patients to a gynac or an endocrinologist for synergistic treatments.
Yeah, definitely that's true. In fact, especially over the last decade, we all know that hormonal problems such as PCO, they have become very, very important. They are being detected on a very regular basis. I think the patient might present to us with acne, but it's very important for us to take a look at the patient as a whole, because do they have hirsutism, do they have obesity, do they have menstrual irregularities, and any other signs of an underlying hormonal problem, which we would like to then further investigate with a hormonal assay, or we would like to refer for an ultrasound. And I agree with you completely. It's always best to treat these patients along with a gynecologist or an endocrinologist, because it's very good to give a multi-system overall approach rather than just we trying to manage them. And also endocrinologists are much more familiar with the long-term use of anti-androgenic medications, etc. And in a lot of cases of acne, we find them nowadays resistant to just the routine types of treatment, by which I mean the standard topical, the standard oral antibiotics, and even in certain extent sometimes to isotretinoin. And that's where we have to presume a hormonal basis is underlying it. And today, medications like metformin have become part of the routine management of acne. They do help to reduce weight, they do help to bring the acne under control and all the other manifestations of the hormonal state. They need to be used over a longer period of time, and definitely all these medications, including means in addition to metformin, even oral contraceptives or others, we need to have a little bit of more knowledge on them, work very closely with our endocrinologist friends, our gynecologist friends, treat the patient as a whole. But these are now a great addition to the armamentarium against acne. And it does go a long way into making sure that the patient gets relief in a faster and a more sustainable fashion.
And we need all these oral medications synergistically with our devices, which can be either lasers or non-laser devices like a fractional radio frequency. Now, why do I say a needling radio frequency? Because additionally this needling gives heat, which does not allow any infected acne to spread. It kills the bacteria, and in addition it also treats the scars. Now I prefer to give a very low dose of oral isotretinoin if it is indicated in the patient and the patient is agreeable to it, because it shortens the use of the devices. The long pulse YAG, I think you will be able to speak better on for scar treatments, because it reduces erythema, it reduces telangiectasia, gives a very good glow, as well as it starts neocollagenosis for the scar healing. What are your take on it? Because you all use a lot of long pulse YAG treatments.
Yeah, so where devices are concerned, I would say the first step might be to actually make the acne settle down a bit. But for active acne, we are in fact using carbon peeling with the Q-switch NDAG also. And in many cases that itself, because today a lot of people have the Q-switch, so it's also availability of technology. Since India is a very pigmentation, prone race, most of the young doctors or all doctors who start this kind of practice would invest in a Q-switch NDAG, and sometimes that becomes a very important addition to your therapy of acne and active acne. And when it comes to the bit of scarring, resurfacing, the microneedling RF, I find that very, very useful, because yes, it does both. It resurfaces, it causes the micro, the trauma, the thermal damage, and you can also use it as an infusion. You can actually infuse active solutions right on the skin. And other than that, then the resurfacing lasers, the fractional lasers, all of it, I don't see that any one thing is the magic thing. It's really important to combine. It's important to understand an individual skin and not say that everybody is going to respond to.
We need to tailor the treatments
we do need to.
the patient.
Yeah,
because
we do.
See active
We do.
acne, non-active acne, we see pigmentation, scarring, and we decide what modality of device we use or what infusions. Sometimes I think we use even retinol, topical retinol after doing a microneedling RF. And even a long pulse YAG helps. Like you said, a Q-switch gives brilliant results sometimes with carbon, but you have to tailor it, because it's it's not 100%.
And everyone will not respond the same way. With acne, it's going to be a long association, and there's going to be a lot of anxiety, because they're going to burst out in eruptions, and it's going to settle down. And the course of acne is such that it is going to come up again and again over a period of time.
We need to put chemical peels also
yes, definitely. There is a point at which chemical peels really help to settle out the active lesions, especially the grade 2. Grade 2, maybe early grade 3 also, they do settle out much faster. So, and since chemical peels also overall brighten, just like the Q-switch will overall brighten, so that unevenness which comes from the spots of acne, that also settles down in a very good way. So you're giving an overall brightening and you're managing the acne. And when you give, see, in today's day and age, nobody is patient. So your patients want something really fast and then they are happy to stay the course with you. So if you don't demonstrate in the first week or 2 weeks that whatever you're doing is going to have an effect, then they will lose patience with you because it's a huge cosmetic problem for them.
I have a trick for this. Normally I do a peeling. It could be a AHA peeling along with a 10% TCA or a retinol peel, just to give the immediate effect. And then I start the patient on oral isotretinoin, and then I move them to lasers or to microneedling, RF, so that already they've got a result, and then it is keeping in touch. Sometimes you can do a old-fashioned cleanup, during oral isotretinoin therapy or during your antibiotic therapy, so that the cleanup removes actually the blackheads and the microcomedones. Patients feel they have done something.
They feel cleaner.
And they feel cleaner, and then it also shows a faster healing.
So it's very underrated nowadays, but the good old comedone expression, there's nothing really to replace that. And while maybe we are doing it more with peels and technology, but the good old comedone expressor can never be replaced
with a needle,
with a needle also, like just needle out the comedones. And the last thing that I would like to say is that while we are looking at the face, let's not forget the scalp, because dandruff or dry scalp, body acne, because that's where a lot of your acne is going to recur from. And there's no point looking only at the patient's face. We have to look at the body, we have to look at the scalp, we have to treat all of it together so that finally they go home.
If you have to combine an antibiotic with oral isotretinoin, which does happen many times, either you give a local erythromycin or you can give azithromycin orally. Try to avoid doxycycline or cyclines because they can give you
I personally also prefer azithromycin pulses, because honestly, when people take medications or antibiotics for too long, they start feeling like they're ill. And I think taking it for 3 days in a week and then repeating more frequently, it just helps to control it over a longer period of time.
I give it for 6 days.
Okay, 3 days, 6 days, but in a pulse fashion, right? And I think
we've covered most of it. One important thing, those who use makeup, it's especially the new types of makeup which are stage makeup, which have gone into pret line, please use a gentle wash first to remove the makeup and then use your makeup remover and then put a little bit of moisturizer. This is the best way to prevent acne which comes because of the occlusive effect. And if you are going swimming, then put a layer of Cetaphil or some form of moisturizing cream which acts as a barrier. And a sunblock, so that prevents the chlorine from causing any form of chlorine acne, and plain rinsing off with water when you come. I think we've covered most of it.
So the last point, I mean, since, which is just on the daily care routine, and that's a wonderful point, because the daily skin care, the cleansing, toning, correcting, moisturizing, that's very, very important in preventing outbreaks. So while we are going to treat you, but you have to have in your kit your cleanser which has maybe a little bit of AHA or Sally, your toners.
We use just moisturizing, simple
and some kind of a hydrator, nourisher. Also, you would need to use a sunscreen, maybe a gel format sunscreen, which will not cause you breakouts of acne, and a little bit of a night gel. Would also be good in the intervening space when you are not being actively treated with drugs or other medications.
For young dermatologists, please tailor the need to the patient. See whether they are in an AC environment. How is the environment? Like for us in the UAE, it's a very dry environment. So we don't use any forms of salicylic.
I'm a cosmetic dermatologist and I'm practicing in Mumbai. The name of my clinics is Cutie Skin Solution. And I am by qualification a dermatologist, but by passion a cosmetic practitioner. So thank you Derma TV and Torrent and Dermacon for inviting me here and giving me the freedom of speech, because I love to speak. Now when I was asked the topic, and it is because random talk, So I thought that I should address something which is very close to my heart, and which is grooming, overall grooming, and how important that is for doctors. Like, you know, in this conference we have a huge gathering of dermatologists from India and also from abroad. So in general, I think it's very important that dermatologists dress up well, because not only because it's important for our own confidence, it's also important because our patients, they look up to us. Somebody entering our clinics, and if we have a good skin, if we have you know, well kept hair or nails, or you know, you are in shape, that of course speaks a lot to your clients. This conference, particularly between last Dermacon and this Dermacon, I have lost around 10 kgs of weight. I know a couple of my colleagues thought that I have even undergone a gastric surgery, but I just want to say that I have not undergone any surgery. I have just lost weight through intermittent fasting, and in intermittent fasting I am not following any particular rule. All I am doing is that I am only taking a single meal, which is dinner. So for all those who are watching this TV, and if you really want to lose weight, then I think the only solution is to cut down on the diet. So, you know, in the past I tried like keto and, you know, eating small portions, taking certain pills, nothing helped. I also say that I am very lazy. I don't really exercise. So that's bad. I shouldn't be doing it, but that's what I do. So what I did is I started eating a single meal a day, which was dinner for me, which could be any meal for you. So that helped, and you know, I think over a period of 3 to 4 months, I've lost around 10 kgs of weight. So that's good. Now coming to skin, which I'm an expert with. So skin starts right for all of us doctors before we actually go to advise our patients. So for me, I'm very particular about my skin. I didn't grow up having good skin. Not a teenager who had I was not taught the basics of skincare while growing up. You know, it was more, I remember I grew up in Mussoorie, which is a hill station in North India, and there wasn't much concept of skincare. So, you know, for all you youngsters, I think you are really in very good times where you have such amazing products to use on your skin. So as of now, my skincare always is like use a good cleanser in the morning, then I use a serum, then I use a sunblock, which is okay, not really regularly, but I'm very particular about putting a moisturizer. And then on top of that, like today, I have put makeup. So, but then before that, there are 2 to 3 layers of serum and moisturizer which goes in. It's not like you just put a makeup and just dab it on the skin. It doesn't work like that, right? So the skin has to be hydrated, supple, soft, moisturized, and then you just need very minimal touch of makeup. Of course, I love to do eye makeup, lips. That's different, but I haven't put a thick layer of base, and that's where it helps. Now, for those of you who have acne scars, who have pigmentation, remember that night care is the most important part for you. So night, what one can do, you can start by removing the makeup off if you have used the makeup in the day. Even if you have not have colleagues in Delhi, you know, so of course we need anti-pollution skincare, right? So that's the first thing, that, you know, use the ingredients and the texture of the cleanser. It's very important, right? So after I wash my face, then I personally do not use a toner. But if you are somebody who has oily skin, acne prone skin, take a little toner on a cotton and then dab it on the face as well, nicely, and give it like 30 seconds for it to get absorbed in the skin. The next comes is an elaborate moisturizing routine, which I love. So I use retinoids at night. I also use a lot of moisturizer right from my hairline down till the neck. So I think that for us dermatologists, we have to have the best skin, right? Any doctors, any specialty, you know, any film star, any model, any specialty, dermatologists should have the best skin. Isn't that right? So I think it's very simple. 5 minutes in the morning, 5 minutes in the night, and I can guarantee that most of the problems on the skin can be taken care of. Now coming to procedures, of course we should try all that on us. I do Botox, not filler really, to have done once long back. I tend to do peels at times. I am in love with Q-switch NDX, so I do that kind of once a month. I do facial. I have done threads for my face. I have also done HIFU for my double chin and to get a contoured chin. And I Botox myself very, very regularly. I've been doing that from last 15 years. So please don't shy away if you have to use these procedures on yourself. Why should you? Right? We are the ambassadors of these treatments. And if we do not use these treatments on ourselves, then how could you have conviction in what you are selling to your patients, right? You are the role model for your patients, so that's very important. So this is skin. I think half of the job is done if the dermatologist has a good skin. And I think if one person has to have a good skin, it has to be dermatologist. Dermatologist means good skin, period, right? Next we move on to grooming, because I still have time on my timer, is hair care. Now for hair, you know, as doctors we tend to tell patients that don't color the hair, it's not good, don't blow dry the hair, it's not good. I kind of differ a bit with this because here I can express what I feel. So I do color my hair regularly. I have also done a lot of blow drying, curling, using tongs. I've even permed my hair, right, because in general my hair are very silky. Why not? We know what kind of confidence, you know, doing hair or styling hair can give to us. I've also gone ahead and done a hair transplant. So if you see this hairline, I didn't grow up having this hairline. I had a, this was kind of much behind. So this kind of an inch of hair was never there. So last year I did a hair transplant with a colleague, Dr. Pradeep, and he's done a fabulous job. So this is the kind of hairline which I wanted. So, you know, I can just tie my hair back and, you know, I can still be comfortable with my hair. And, you know, like, in fact, it's hot, so I do feel like tying my hair. Oh, sorry. Yep. So I just wanted a hair which I can tie. I don't have to style so much, and that's what I did with hair transplant, right? Now next comes is nails. I am often told, you know, I know my colleagues, all dermatologists who are seeing this, they know about my nail story. So I have been doing this acrylic nails followed by now gel nails from last 15 years. 15 years I have been doing my nails. Now the question is, have they spoiled my nail? Maybe, I don't care. Maybe they have spoiled, but I'm always going to keep doing this. I'm sure that, you know, I can afford doing my nails. I think there's some noise anyway. So, you know, so groom yourself how you want, you know, what you feel comfortable with. And trust me, this has a lot of impact on your patients, right? I think there is some noise. Should I continue? Okay. Continue? Okay. All right. So we've done the skin care. Now the grooming and, you know, the use of nails. You know, I kind of love to do nails, as I said. Now next comes is the kind of dress, perfume. It always feels good if we dress up well. Like you can see, most of my videos are in red color. This is one top which I've worn so many times, I hate to repeat it, but I love this because I feel that I come out best when I wear a red color. So it doesn't matter if there's a repetition, but I love using red color and that's what I do. It kind of complements my skin and myself. So I think yeah, so this is a bit about grooming and all for dermatologists, very, very important. Now let's talk a bit about beginners, because in this conference I was asked a lot about which technology one should start with. Right, so this is important and we are going to talk for 4 minutes on this. If you are a beginner, can I have some water? If you are a beginner who is actually starting out, I would suggest, first of all, do not compromise with the type of machines which you are buying, right? Don't fall trap to the cheaper Chinese or, you know, this sold on e-mart or online. You need a proper training. You need an understanding of the parameters of the system, right? It's okay if you can't afford one, right? Whenever you will be able to afford, you can then get the technology into your practice. for now, everybody can start with radio frequency and peels, right? Radio frequency and peels both do not need a lot of investment. There's a short learning curve, and you can at least start catering to your patients, you know, who come for pigmentation, who come for warts, right? So start off with getting a good cautery machine, which will cost you somewhere, I think 20,000-30,000. You should get a good cautery machine if you can't afford like an element. And then you can start with peels. Start doing peels. Now peels are categorized typically, you know, there are peels which are milder peels, which are more of party peels. Then there is something called combination or designer peels. And then lastly we have deeper peels, or which are used for specific indications. Everybody can start off with milder peels. Like you could have milk peel, lactic peel, pumpkin peel, pink peel. You know, there are a lot of milder peels. Most of the peels are either gel based, or they are steps which are exfoliation, moisturizing, mask. So start doing that. That's important. Not much investment needed on your part. If you ask me the laser which you should have, Q-switch and laser hair removal are the two most important lasers which every beginner must start with, right? So I repeat, it is laser hair removal. I love the triple technology, but of course I started my practice using diode, then Nd:YAG. Now I have moved to triple wavelength. So once you have the triple wavelength lasers, I think it's very safe. You can cater to more type of hair, darker skins, medium thickness hair, fair. And so these are the lasers. Then coming to Q-switch, the most important laser in my setup, and I call it my, you know, kind of a lifeline, is Q-switch Nd:YAG laser. I'm sure most of you already know that. Now what you need to know is that what all you can do with Q-switch Nd:YAG laser. Actually you can do a lot with Q-switch Nd:YAG laser. It is a fairness laser, it is a laser to remove tattoos, this is a laser to reduce fine hair on the face. It is a laser which you will be using for brides to lighten the whole body. It is also the laser, if you want to do a treatment which you can be safe, then there will be no downtime. That's Q-switch Nd:YAG laser. If you also want to get into you know, more of bridal care, you will definitely want to have a Q-switch. You are dealing with people who want to have a party or a function tonight, then only thing which I can think of is Q-switch Nd:YAG laser. That's important. Once you have the hair removal laser and you have the Q-switch Nd:YAG with you, then next important is that you get into learning injections, right? Now, traditionally, botulinum toxin and dermal fillers is not a part of your learning, right, in a dermatology curriculum. Of course, a lot of you may be taking interest and learning it otherwise, but this is still not a curriculum, which is sad. But then after you pass out your post-graduation, I suggest that, you know, you work with somebody, understand the limitations, understand what a product can do on the face, and start injecting. Start off with a family member or a friend. You can ask a mentor or somebody who is already injecting to, you know, guide you. You can also attend these training sessions done by the pharmaceutical companies and learn injections. It will give you a different thrill. It's more like, it will put you above certain other people. It's like my race against this voice going on. So learning injectables is very important, right? So let's sum up the whole thing because I have 10 seconds. Grooming is the most important for dermatologists. Weight loss, if those who are obese, hair transplant or any cosmetic surgery, don't hesitate if you have to do, right? For the beginners, have a laser hair removal, Q-switch Nd:YAG laser, and learn to do your botulinum toxin and fillers. And all the best. And if you want to reach me, then my Instagram handle is cutis.in, cutis.in, and my website is www.cutis.in. Thank you so much. I sign off.
Hi Maya, how are you doing?
Hi Jayashree, great. How about you?
Very, very good. So you've been in the industry, you've been one of my mentors, and you've been here for a very long time in the field of aesthetic dermatology. How did you enter this fillers and botulinum toxin field?
You know, I always wanted to have a niche practice. And then to have a niche practice, you have to stay on track. So I was just wondering what was the latest things that were not in our country, and I thought that would be the best thing to do. So I adopted this scarcity technique, meaning there is a need and no supply. So I found that these two procedures were the topmost that was needed for our patients. So I actually went out to learn them, and once I came
because
back,
in those days, and in fact even today it's not introduced, it's not there in the curriculum, but yes, we have a lot of workshops and stuff. But back in the day when you started, I mean, Botox and fillers were like completely, where did you learn and how much time did you take to actually get the confidence? How did you convince your patients?
See, actually I went to Cleveland Clinic because that was a place that offered me an observership, and I made sure that I visit all these departments which were not there in our country. So they had a Botox department, and they also had a filler department. So when I went in, so I actually thought it was a most difficult thing to do, and I thought it was dangerous to do. But then it was like a child's play when I saw them doing things. So as soon as I came back, I was wondering how to source these products. Then I found somebody who was visiting our hospital from the United Kingdom. So he was a plastic surgeon, and who was aware of this product. So I asked him if he could bring it with him to try it on few of my patients. So I was actually doing small numbers to start with. One is because of the trepidation, and the other thing is I wasn't too sure about the acceptance in our patients. And by the time I got familiar with these products, the Allergan was in with the botulinum toxin.
Okay.
So it just tided
so
over my crisis.
you're one of the pioneers of injectables in our country, right?
Yeah,
because you brought it before it even came into the market. So
that's right. I really didn't know that I was getting into injectables. I think unknowingly by default I got into injectables.
And that's so good because you have taught us so much, and you've not hidden anything. You've brought about clarity. You've taught us. I mean, I remember always running for your lectures, as a student, and even later on, even till today. So, what is the difference between then and now in terms of patient awareness? I mean, do you? How at that time, like people didn't know so much.
At that time, patients were a little naive. They would just trust me, and then based on my recommendation, they would take it. And of course, I used to do it only on selected patients. But now I find that patients' awareness has increased. So some of them come with the request, while some of them go on the internet, Google all the negative aspects of it, and they refuse outright. So it's actually a balance between patients who are able to accept it and patients who are refusing it. So now it's actually even harder to convince because they are all over the internet, they are over the magazine, both good, bad, and ugly of the injectables.
True. Because what's happened is, these pillow faces and the duck lips and these kind of things have come about, and people have over injected, and it's now no longer natural. And people are now coming back to we want to look natural and we want to look, and that's probably one of the reasons why it's getting more difficult to convince them, because the moment you say injectables, they run away. We don't want a frozen face, we don't want duck lips, we don't want pillow faces. I face that in my practice every day. Do you face that too?
Of course, they freak out. Some of them really freak out, and when I use the word Botox, they said, oh, I don't want a paralyzed face. When I tell them fillers, no, I don't want a fat face. They all know only the negative aspects, because only the negative aspects are blown up in magazines and in other places, you see.
So how do you convince them?
Jayashree, before me telling me how I convince the patients, now
you have to
doing
convince
more
yourself
patients than me. So I think that's the current scenario. So now you must tell me how you have been able to convince so many of them to do it. I think that's the truth.
So I have these modules in the clinic where I have the entire science, laid in either in my laptop or it's there on our iPads, where the anatomy of aging is shown, just like we have our PowerPoints, but in a more simple way. So how the bone changes and how the fat changes and how the muscle changes. So you talk science to them, that this is what is happening, and your foundation is crumbling down. You have to build that foundation, and so you will be able to build that foundation with the help of fillers. And that's how I actually start with science, and then I show them some of my before afters. I do invest in a little bit of free treatments once in a while. I do injectables for free in patients who are willing to have their pictures being shown to others. And so I have not too many. I have maybe one indication each, and then I will show them to those patients, and I'll actually, what happens is, in our chubbier face, if you actually inject the peripheral area and you create that lift, you're actually creating a narrower face. So when you show them that before and after, or you show them a young face who needs tear trough, and you do the tear trough and it looks good, I think the science and the before afters together convince them more. And also tell them about the fact that the face is full of blood vessels. So they can bruise, but not to get worried, because that bruise is going to go eventually in about 5 days or 7 days. So that's my modus operandi.
How do you manage your Botox patients? Because, more than the fillers, the refusal for botulinum toxin is more.
Yes.
Immediately they say, paralyzed face, I want to have my expressions, and I don't want anybody else to know that I've had Botox. So how do you manage that?
So my dosage is very different. I think once we had this discussion, and I literally tell them that it's baby Botox, because I will do less number of units and keep the expressions intact. For example, in the frown, if I see a prominent frown, I would not go beyond 12 units. I would even sometimes just do 10 units. So the frown is there but not there, you know. So I usually do that when it comes to Botox, unless I'm doing masseters where, you know, in a female, where I do end up doing 30 units also, or sometimes even 40. Sometimes even 15 and 15 are enough. So it depends on how the bulk is. But when it comes to the face, crows I usually do between 7 and 9 units. I do not go beyond that. My frown is always 10 to 12 units, and my forehead is 5 units, and that's it. And that sort of, you know, and I tell them that, look, your lines are not going to disappear. It's just going to look softer and fresher. And I think that is the key, because that's what they want and that's what we also want. We don't want to, you know, tomorrow if we do something and the patient goes to a party or wherever and they say, who are you going to? And it's our name which ultimately gets spoiled. So,
which means
so
they have to inject more often?
Yes. So when you're doing a lower dose, maybe not really too often, but maybe once in 3.5, 4 months, they still come in.
How do you manage your celebrity clients? I know you are up in numbers in treating celebrity
It's the
patients,
toughest
so
thing to do.
I
Trust
agree.
me, it's not hunky-dory. It only looks really lovely, but there are days when we are like, you know, we've had it now. I don't think I want any more. But we have to have a separate appointment system for them. So we do not have online appointment systems, because you can't have any patient go and schedule an appointment for themselves, you know, because then that they can clash with the celebrities. So I work from 8 in the morning to 10 in the morning for celebrities. So actors who want to come in, they come in during that time. It's not every day, but on days that they want to come. And then again between 7 in the evening to about 10 in the evening. And between 10 and 7 is the normal patient's time. So this is how, and then of course, luckily now I have a clinic which has an entrance which goes right behind. So your car can come right behind, and the lift, they get down and the lift is right there. So nobody from the front gate sees who is getting out. And I have 3 doors to my clinic. So one is the common entrance and 2 are the celebrity entrances. So if I have 2 celebrities at one time, so it's like a semicircle, my clinic. So so there are 2 doors, you know, opposite each other. So we sort of hide them into that room and this room. We pack them. So that's another thing we do. And of course, what is very important is to really discuss things with them and give them a real picture. That's very important, because they expect miracles. And they expect no bruising, they expect instant results. So the expectations are very high, and so it's very important to sit and counsel them and tell them that no, these things. And they do not allow you to take photographs. So what I do is I tell them, if it's just the eyes or just the lip, I tell them, look, I'm going to click and show you. And I actually show them the photographs, and I show them one picture before their photo, that so they know I haven't taken their full face. Or I take the photographs with their camera and I tell them, this you can't delete, because this I have to keep as, you know, my reference when I finish injecting you. And never forget to take their consent. And always, you know, if you give in to, you know, can you come to my house and inject, or can you do this? If you give in to that, then you're stuck. So that's something I put my foot down and I tell them that, look, except for one person, for everybody else, actually for 2 people, but for everybody else it has to be come to the clinic. Now sometimes they do want to come between a 10 and 7 slot. So you tell them that, okay, appointments are full, we'll put you in from one door, because we have 3 doors, but you may have to wait for the main doctor, for Dr. Jayashree to enter, and you may have to have the subordinate doctors see you. So explain to them and they come in. So these kind of things, we do not take any favors from them.
Exactly.
So I never ever in my clinic, none of my staff are allowed to take photographs with the celebrities. There's no wow factor. We teach them no expressions. You can't show them, you know.
Exactly.
And at the same time, I mean, of course, if you're meeting at parties and stuff and we've taken photographs, that's different. But otherwise, in the clinic, absolutely no favors, no photographs, because then they take you for granted.
Exactly.
And we have to maintain ethics. We can't spill out names to other people. We, you know, also, this is something that they like about me, because I do not, my lips are sealed.
there are days, there was this very nice, funny incident where the husband and wife were both coming to me and both didn't know they shared the dermatologist.
That's
you
funny.
know. And it happened for almost 2 years. Till they, till one day they said, my dermat is better than yours, and it happened to be the same dermat. And they said, my God, this is ethics. So I think that really helps.
True, very true, because I think you have to maintain confidentiality.
You have to maintain, yes.
And that's how I do too. We don't take photographs and staff are not allowed, and no juniors are allowed to come inside when I'm doing the procedure.
Yes.
Because they don't like
absolutely
to be seen
they
that
don't
they
like
are
to be
undergoing
seen.
the treatment, and they have the special entrance to come in and go out. I think that's very important. And one thing I found is you can be friendly with them, but you should not make friends with them.
Correct. That's the key. You cannot be friends with them, and that's a wonderful thing you've said. You can be friendly, but don't make them your friends.
Exactly.
You know, that's where you begin to lose
and
it all.
Nowhere in our Instagram or Facebook, we do not take pictures with them. We do not post pictures. Because I see the younger generation take so much pride in, even if they've come for a consult, leave alone a procedure, they immediately take pictures and post it on the Instagram. I think that's not ethical.
It's not
we
ethical.
are professionals.
Yes.
They forget that we are professionals. I think this is a message we would like to, otherwise they will lose confidence in all the doctors they meet.
Absolutely, yeah.
I think we belong to the older generation where we maintain ethics, we maintain confidentiality, and yet we are able to achieve what we want. I think that's a great message you've conveyed, and I'm glad that both of us are in the same level of thinking.
Yeah, I've learned it from you, Maya. Don't forget, you
my
are
God.
my mentor.
Jayashree, and now I'm learning it back from you.
That's very sweet of
what
you.
I sow, I reap.
Yeah, it's always such a pleasure, you know, to be with you, to meet you, to learn from you, and you know, I feel blessed that I have you in my life. Thank you so much,
Oh,
Maya.
how sweet of you, Jayashree. I think I have no words to express my thankfulness, and I really hope and make you and see you on the top of the world.
Thank you
I know
so
you
much.
are already on
No,
the top
I have
of the
miles
world.
to go before I sleep, but with support from people like you and all the encouragement and the help, because whenever I'm in trouble, I call. So thank you so much.
Thank you, Jayashree. It's been lovely talking to you.
Same here.
And all the best.
Thank you.
Welcome Dr. Petro Nenov. He is from Germany. Welcome to India. And I hope that you are enjoying Pune and our hospitality.
Yes.
Sir, I would like to ask you how frequently you see a superficial fungal infection in your country?
Oh, thank you for invitation and for this interview. My name is Nenov, as you said, and I'm from Germany. I'm a dermatologist and I'm working in a lab, both in a private lab for microbiological diagnostics and for mycological diagnostics. We are very specialized. And in our office, I see a lot of older people in Germany which are suffering from fungal infections. These are fungal infections of the feet. it means tinea pedis for dermatologists, and tinea unguium, what is onychomycosis. And this is so frequent, around 10% of people living in Germany, of all people, are suffering from onychomycosis, and we have a bigger part of older people, and it's increasingly seen. Another kind of infection is tinea corporis, tinea cruris, but it's quite others than you see here in India. We have patients suffering from, older patients suffering from tinea corporis due to Trichophyton rubrum, and not to Trichophyton mentacrophytus or Trichophyton indodigitale like you have it here now increasingly in India. And the other part, yes, of patients we are seeing in our offices are children, young people, which have the risk for a fungal infection of the skin and of the scalp, in particular of the scalp, as a tinea capitis or Escherichia coli, due to contact to pets at home, or maybe at school, or in the kindergarten, wherever. Yes, we have a lot of pets, maybe rabbits or rodents, and cats, of course, and dogs, which are living together in families at home. And they are carrying fungal agents. It means dermatophytes. These are zoophilic dermatophytes, Microsporum canis, Trichophyton mentacrophytus, and also newer dermatophytes, which are now known maybe for 10, 15 years only. From Asia, it came Trichophyton benhamii, which is source of infection and is the source of infection in Guinea pigs. And we have a lot of Guinea pigs as pets in Germany homes. Yes.
I'm interrupting you. Most of the time, the fungal infections are diagnosed clinically.
Yes.
But what procedure you do to confirm the diagnosis in your country?
This is very
I mean to say, do you do potassium hydroxide mount or fungal culture in each and every patient you encounter in your practice?
Thank you for this question. It's very important. Most of patients will get a mycological diagnostics. It means we take skin scrapings, we take nail material, we take swabs from patients, and we would like to make sure that the patient is suffering from a fungal infection. And in the lab, or maybe in the dermatological office, we are dealing with KAH preparation, or maybe a variation of it, which is much more sensitive. This is a fluorescence optical preparation, chalcofluor. It's also known here in India. Second basis of fungal infections diagnostic is culture, cultivation of the material to find the growing dermatophytes or maybe yeasts or molds. This is the common regular diagnostics. But what is increasingly done in Germany, maybe in the last 2-3 years, and it's very important now, is the molecular diagnostics. It means we try to find the DNA of the fungal agent of dermatophytes directly in the clinical material, what means in skin scrapings, in hair roots, or maybe in nail material. It works very fast, very sensitive. This is a PCR diagnostic, real-time PCR diagnostic, or the highest level we will get by sequencing of the DNA of the fungal agent, and so we can have a very specialized diagnostic.
Dr. Nenok, my question is, do you wait for this diagnostic test to become before starting the treatment, or you start the treatment after taking?
This is a very important question again. Yes, to be realistic, of course, in Germany also. We have a lot of colleagues, dermatologists, they do not wait. They make the diagnosis on clinical picture, and they say, now I treat empirical. Yes, it's empirical treat because they have experience to say this is a fungal infection of the skin or of the nail of the scalp. But the biggest part of dermatologists is using a mycological diagnostic, a laboratory diagnostic, and they are waiting. First, maybe they are preparing KOH preparation. If this is positive, they are starting by topical therapy, topical antifungal therapy, and if the culture is positive or maybe the PCR is positive, then they are starting by oral antifungal
topical
therapy.
therapy do you prefer in your patient?
For topical, yes?
What topical therapy do you prefer in your patient in Germany?
In Germany we have a lot of azoles, but maybe more the older azoles, what is micronazole, this is my favorite, and clotrimazole, which is also my favorite. But we are very frequently are using cyclopirox as cream or as
do you think
solution.
miconazole or clotrimazole works in your patient? Because here in India we encounter that these two older generation azoles are not even working in many of our patients.
Yes, at the moment we have the good situation that these topicals I have mentioned, they are working good. But the problem may be in the future, and it started now, we also have these terbinafine-resistant dermatophytes which are available here in India, and first patients are to be seen now in Germany also, and we will see what happens there. But at the moment, the older azoles and the amorolfine shows very good results for topical treatment. Yes, or both in tinea corporis, tinea pedis, but also in onychomycosis as nail lacquer.
What about luliconazole?
Yes, I know it, of course, because I'm familiar with Indian dermatology a little bit, and I know it is very effective against the T. mentagrophytis genotype 8, which is prevalent in India, but we don't have it in Germany. It's not approved in Germany for use in medicine. Until now, we are waiting for luliconazole. Yes, it would be nice to have it.
Now, what about the systemic antifungal agents you use in your patient? When you think that the patient requires systemic therapy when it is extensive, or patient is suffering from tinea incognito or mycosis granuloma?
Yes, I am a fan of oral or systemic antifungal therapy. And in particular patients with onychomycosis, you have to treat them by oral agents. And the therapy of choice at the moment in Germany is terbinafine. Yes, 1 tablet a day for 3 months, or maybe longer if there's no good therapy response. Second choice is fluconazole. Fluconazole, we have also good results in dermatophytosis. And the third choice is itraconazole. Yes, we don't have griseofulvin. It's not longer available in Germany. This is a little bit pity, but we have to deal with this. And,
what doses of itraconazole is available in your country?
Itraconazole?
Itraconazole.
We are using itraconazole for adults. It's approved, but it's not approved for children.
No,
for
in our
people.
country, it is available in the strength of 100 milligram, 200 milligram, and even some companies have come out with a 400 milligram.
Yes.
Sustained release tablets.
Yes, I have learned in India that the only way to treat these chronic recalcitrant dermatophytosis due to T. mentagrophytis genotype 8 by itraconazole 400 milligram per day. This is an off-label use also here in India for 4 weeks, maybe 8 weeks, and it seems to work. And we have first patients in Germany with the same Indian fungal infection, and we are using it also 200 milligram or 400 milligram per day itraconazole for 4 weeks or maybe longer. This is the only way to treat these patients at the moment, and we have to speak with the patients, and we will get their agreement, and we have to do it. Yes.
Okay. My next question is, what about the older generation griseofulvin antifungal agent?
Yes.
What is your comments on it?
In Germany, it is not so common in the last maybe 10 or 20 years. We had not so much children suffering from dermatophytosis of the scalp, tinea capitis or Kirian-Selsi, and so it was used very rare only. It resulted that the company said it's not longer useful in Germany, and we don't sell it, and it's not available in Germany now. And we have to treat patients without griseofulvin. But I know.
But what about the Kirion? You said that the tinea capitis and Kirion.
Yes.
What do you prescribe in these cases?
If we have a zoophilic infection, maybe T. mentagrophytis is zoophilic strain in Germany, we can treat it very good by terbinafine. but it's off-label use, yes. Second choice is itaconazole for Kerion Selsi, yes, and we don't have grisefolvin, and we don't need it at the moment because we don't have resistance at the moment, but it can change.
In our country, India, many of the families are affected. The members of the family, 3-4 members of the same family is getting affected. What is your comment on this? Do you encounter such kind of clinical situation in your country?
At the moment, we only have single patients and couples maybe which are affected within one family, but this is a rare scenario at the moment. But in India, I know it, of course. This is a terrible spread of this fungal infection, and but I see the reason why should be the use of these cocktail creams containing clobetasol, and this should be stopped in India. There should be find a way to stop this, and the other way is to look for patient's immune system. Maybe there is some disturbance. They are have a predisposition for these fungal infections. We don't know it at the moment, yes, and we have to initiate a lot of research on this field, yes.
What about the special situation like fungal infection in pregnant women?
Yes, yes, in Germany, our treatment regime is to treat the pregnant women only topically. We don't treat pregnant women orally, yes, only very, very rare. And if we are using itaconazole. But I know India, we have a lot of pregnant women, patients suffering from these recalcitrant fungal infections, and yes, this is an off-label use to take oral antifungals, and I have heard in India they are treating by terbinafine, maybe other oral antifungals, but in Germany we are waiting for the time after the pregnancy and after lactation, and then we are starting maybe in onychomycosis in a formerly pregnant woman, and then we...
So it's better to defer the treatment till the delivery, and then you can go for a systemic therapy.
Yes, this would be my advice, yes.
And you want to prescribe topical treatment in pregnant women.
Yes, yes.
What about the elderly people, like the people who are above 70 years of age?
Yes, we have a lot of them.
Yeah, what do you think? Is it topical or systemic or combination of both?
It depends from the willing of the patient. If he has an onychomycosis, tinea pedis is very affected, then and he had the will to be healthy, and then I treat all these patients orally by terbinafine, by itaconazole or fluconazole with onychomycosis. Yes, and but in older patients, you have a lot of other drugs they have taken. Yeah, and it's a little bit dangerous maybe for interaction between antifungals and other medications, maybe lipid inhibitor or whatever. And you have to be aware that there's no interaction. But if there are other drugs, we are using a low dose treatment, with what means 1 tablet a week only. 1 tablet of terbinafine a week only for a long duration in these older patients. And it seems to work in onychomycosis. Yes, this is interesting, but we don't have good studies on this. Yes, it's an off-label use.
Okay. What about the fluconazole in elderly patient?
Yes, there's no problem. I believe so. Yes.
What doses you prefer?
In tinea corporis, 50 milligram per day, 50 milligram only per day for maybe 4 weeks. In onychomycosis, we are using fluconazole as an 1 weekly dosage only. It means 150 or 300 milligram once a week only.
For how long?
Oh, that's a good question. For 9 months, maybe 12 months.
So
yes,
we use
a long time
6 to 9
treatment.
Months.
Yes,
6 to 9 months.
Yes.
So what is your advice to us or your experience in treating fungal infection, if I say to summarize in 1 or 2 sentences?
It's exciting and it's horrible that fungal infections are absolutely increase to be seen, and not only in India, but in a lot of other countries, and we should be aware, we should make a lot of research on this field as dermatologists to find solutions for this absolutely big, great problem.
Thank you.
Okay, thank you again also. So.
Erecto, nice to see you again in Pune for this Dermacon conference. We are really grateful to you for teaching us dermatosurgery, dermatology and hair transplant surgery. Just wanted to ask you how this thing has evolved in your practice. When did you start and how did you come up, and that is what we would like to know from you.
I'm 40 years, I'm a dermatologist, but 30 years ago I started to do hair transplant. And of course, was my beginning, and the 30 years I have experience. But I remember 25 or 26 years ago, I went to Pune to visit my brothers, Dr. Naren and Dr. Sarah Mutalik, and we did a first hair transplant, I think the first hair transplant in Pune,
Yes.
and one of the first hair transplant in India, and we are the pioneers in the hair transplant in India. Nobody knows what is hair transplant.
That's right.
And people say, what? Hair transplant? Is possible to take hair and put in another place? Now it's so common, so popular. Every city are doing hair transplant. But 26 years ago, we started to do this, and we continue to do this.
Yes, really, but I would like to ask Alex, I am becoming very nostalgic and maybe emotional also. In the year 1998, actually Naren had given me your card and I visited you. First you taught me the facial surgery and took out my fear of the blood, and we did many basal cell carcinomas, melanomas, and then you called me to assist you for hair transplant. It was quite tiring at that time, but it was a boon for my knowledge itself. I'd like to ask you, what made you think of hair transplant? That how did you decide that I should go for hair transplant and this branch will boom like anything?
What made you select this?
When I did my resident in dermatology, I did 6 months plastic surgery. And we went to the department of plastic surgery, we went to the Congress of Dermatology Surgery in Jerusalem. And I saw a little television, white and, black and white. There was sit on the chair, a little one, and a doctor from France showed that he's doing hair transplant. I say, what? It was in 1984, 1985. I said, what? It's possible to take hair and implant? And I said, this is what I want to do. And I contacted with the doctor. There was Dr. Pierre Boana from France, from Paris. I contacted with him. He invited me to Paris, and I went 2 weeks with him, and I started to do hair transplant.
Great.
How did you start? You start with big punch and then came to the small punch and strip surgery.
Dr. Pierre Boana, he's a wonderful hair transplant surgeon, and he showed me a new technique with small punches. But everybody did with big punches. And I started to do small punches. But there was a revolution because nobody did small punches. Everybody do 4 millimeter punch. And we start 2.5 millimeter punch.
That time.
2.5. And now we are doing 0.6, 0.7. But in the 30 years ago, it was 2.5. And for the frontal hair, we put 1 millimeter punch.
Great.
And this is how I start. But interesting that now so many people are doing hair transplant. Everybody wants to do hair. The hair is so important in the people. And 30 years ago, nobody think about hair.
Actually, it was a great thing. First, you showed me the complications of 4 mm. And at that time, you showed me that 2.5 is better than 4 mm. But at that time, we were astonished to see your clinic, your private clinic in Ranana as well as in Class Clinic. The name itself proved its class.
Teleshuman.
at Tel Ashomer, and we were mesmerized, and looking at your endurance doing 2 or 3 hair transplants in a day, would like to ask you, how do you keep yourself fit?
You do 2 transplants in a day, plus do
You
your
don't get
surgery.
tired.
Don't get tired. What keeps you going?
I have energy, and today I'm doing 1 or 2 hair transplants a day, and I teach also many doctors from all over the world. I have 100 fellows.
Great.
Yeah, my record, and from India I have 40 doctors.
Yeah.
Great.
But
That's great.
Dr. Mutalik was the first, and Dr. Narendra was the second. And
Yes.
this is the reason I say they are my brothers.
Thank you,
because
thank you.
we are 26, 28 years, we are very good friends, and with the families, and we enjoy in every congress we met.
And you have been to Pune to teach our team right from 2002, 2006, 2010, and you come with your team.
Yeah.
How do you develop your team, your nurses? How do you teach them? Because it's not a single man job.
Not
it is
simple.
a teamwork.
Yeah.
So how do you develop your team?
It's complicated. For the beginning, it's very complicated. It's too complicated to create a team, and the team need to be with you, and to teach them, because 30 years ago was different. Nobody knows about the hair transplant. But my nurses love the hair transplant, and we have a wonderful relationship. And we came from 2 or 3 nurses each time, and 3 times we did hair transplant in Pune, and this I think is my 4th time in Pune.
Yeah, that's right.
Did you encounter any complications, any severe complications during hair transplant? Because looking at the extensive surgery on the scalp, which is a vascular area.
The most important thing is, I think, you need to select the patient. And this is a reason that, for example, I teach only dermatologists and plastic surgeons. Because the dermatologists, they know about scalp, they know about baldness, they know about disease. And this is very important that the specialists are doing hair transplant and not every doctor. Because sometimes a psychiater call me that, or the GP call me that he want to do hair transplant. But if you learn psychiatry, why you want to do hair transplant? Money. But the hair transplant is the dermatological specialization. And a dermatologist can select the patient. And when you select the patients, you avoid complications. Yes. It's very important. And also, you need to have a good teaching, because if you have a good teaching, you know exactly what you do. Especially in India, 2 patients died due to the anesthesia. Because people want to do 5,000, 6,000, 10,000 grafts, and maybe the surgery was 12 hours, 14 hours, and you see, they put so much anesthesia, and they have complications.
Alex, how many grafts maximum you advise in a person who is expert in doing hair transplant?
Yeah, I am not doing more than 3,000 grafts a day, but not for everybody. But if I need to do 4,000 grafts, I am doing 2,000 grafts one day and 2,000 grafts the other day.
Yes.
But I not do 4,000 or 5,000 grafts one day, because it's too much for the doctors and the nurses, and also for the patients. And you create a risk.
Yes.
And in hair transplant, that is a cosmetic treatment, you need to avoid the risk, 0 risk.
Yeah. What are you using after the transplant? A-cell, PRP, mesotherapy.
Growth factors.
Growth factors, what are you using in that?
When you are doing hair transplant, the hair is growing. You don't do nothing in the hair transplant because it's growing. You don't need to create more hair. Right. Because if somebody have a bald area and you implant with or without another treatments, the hair will grow. You can treat the other place that you didn't transplant.
Okay.
what is your opinion about the eyelash transplant? Is it successful?
The eyelash transplant is complicated. I am doing, but I am doing only to repair, not for beauty. For beauty is not good, but for repair, if somebody did a laser or a operation and he loses the eyelash, it's very important to implant the eyelash.
And what is the youngest age you have done transplant?
22, 23. I prefer to do a little bit more older, 24,
Well,
25.
nowadays everybody comes and demands for hair transplant and we refuse below 24 or 25. Is that right?
Yeah, because now, unfortunately, the hair transplant is a business. And now what happened that the doctor is not doing the hair transplant, they delegate to technicians, and the technicians are doing the hair transplant, and we see very complications, no doctors, no dermatologists, and also no doctors. And they spray that you see in Turkey. In Turkey, for example, there are in Istanbul, there are 450 clinics are doing hair transplant. In Israel, only one clinic. In all Europe, there are not 400 clinics. In Istanbul, 450 clinics. Why? Because the Minister for Health allow everybody to do hair transplant. Also a barber, also a butcher, everybody can do hair transplant.
Can we expect stem cells in the near future?
We hope, but not yet.
What about hair multiplication, hair duplication?
Yeah, the same. They are working, there are different centers in the world are working about this. They create hair, but the hair is growing in different directions, and this is a problem.
Alex, for us, you are a robo. Are you planning to buy one more robo in your clinic?
No, because robot, in my opinion, is for the doctor. He don't know to do FUE, or he don't want to do FUE. The robot only do the holes for the extraction. It's too expensive.
Yeah.
It's approximately $600,000, and you need to pay $1 for each hole are doing the robot. And if you have a good hands, you have $600,000 in your hands. And for the company is very good, but for the doctors it's not a help.
What is the tips you would like to give to those who would like to become a hair transplant surgeon? What are the tips to the doctors?
The tips is, first of all, be dermatologist or plastic surgeon. Also go to a place and learn a very good hair transplant, because you need to know all the techniques. You cannot learn one technique because you are not a technician. You need to learn all the art of the hair transplant, and then you decide which technique is better for the patient, and not you take the patient and you give only your technique, because it's not only one technique. It's the same that if you have a laser and you have a CO2 laser and you want to treat everything with CO2 laser. Impossible. You need to have many lasers, and depends the condition you decide which laser to use. In hair transplant is the same. You have different methods and you decide which method is much better for the patient. Sometimes you say, no, you don't need surgery, you need medical treatment. And this is the reason the dermatologists need to do need to treat hair.
Yeah, okay. Alex, what do you feel about coming to India? Whenever you come to India, what do you feel? I mean, what is your...
I love India. First of all, I have my friends, I have my brothers. I love this country, and the hospitality is unbelievable. And when they invite me, I try to come.
Yes, and we are really thankful to you for coming all the way. There was one more conference going on, MCAS, but we are really thankful to you for gracing the occasion, and enjoy the Pune hospitality and enjoy the atmosphere here.
Thank you, Naren. Thank you.
Thank you. Toda Rabba. Thank you.
been hosted by Dermacon 2020 Pune team. And I would like to discuss now how the practice has changed over the recent few decades, especially in various clinical diseases like psoriasis, pemphigus, vitiligo, medical trichology, including surgical aspects of it, social media and dermatology, which has changed our practice very drastically, and lastly about lasers. Now, we should have an open discussion on this. First, we can take the topic of psoriasis. How practice has evolved over years or decades in psoriasis. Can you throw some light on it, Dr. Pandey?
Yeah, indeed, Bhushan. Actually, this has been a good top, and there has been a lot of changes in the dermatotherapeutics and management of various skin disorders. And the one paradigm shift has occurred in the management of various disorders, particularly as you mentioned, the autoimmune disorders like psoriasis, alopecia areata, atopic dermatitis. There has been a lot of changes with regard with newer advances or recent advances that has come up. Even the field of medical trichology and the surgical dermatology, dermatopathology, there has been a lot of recent advances. And I think we must take a cognizance of this because this is going to decide the future of dermatology.
Yes, this could be the future, and maybe our new dermatologists may be practicing this rather than more old molecules.
Yes, exactly.
And how you see psoriasis treatment will change in next few decades down the line?
Yes, I have been, I mean, in fact, all of us has been witness to change in the management of psoriasis over a period of time. Like when we were resident, actually, in that time we were using, as you also must be remembering, the psoralen based therapies or ultra PUA therapy and narrowband phototherapy was in use. But of late there has been a lot of emphasis on the use of immunosuppressive agent. It was long time recognized that the psoriasis is an autoimmune disorder, and the focus has changed from a disorder of keratinization to the immunological disorder.
To chronic autoinflammatory disease.
And so many immunosuppressive agents were developed over a period of time for management of psoriasis. And I would mention particularly the methotrexate, which was actually originated in India. Was found to be very much cost effective in the management of psoriasis. So that was a point actually has changed the practice of psoriasis, and there was a shift from PUA therapy to methotrexate. Later on it was realized that it's an immunological disorders and a lot of inflammatory cytokines do play a role in the causation of psoriasis, and for that various biological therapies were emerged. Actually these are the targeted therapies, and nowadays we have shifted our treatment focus from methotrexate the use of various biological agents, and those agents are found to be relatively safer as compared to broad.
Correct. Now most of the clinical diseases have now shifted their focus from using a broad spectrum thing to a more specific and a goal oriented or molecule oriented treatment. So in psoriasis, how are the things going on or moving on, at least in trial phases, or what we can expect down the line now?
Yeah, psoriasis actually is a global disease, and there has been a lot of patients of psoriasis all over the world. And as I said, we shifted our focus from immunosuppressive agent to a targeted therapy like biologics. The initial biologics that came into market were infliximab, etanercept, and later on adalimumab was also there. And these drugs used to target TNF alpha blockers, but there were safety concerns with regard to infliximab, particularly with regard to reactivation of tuberculosis in a country like India.
Yes.
So in 2015, there was an FDA approval to a drug called as secukinumab, which is an IL-17 inhibitor, and that has actually changed the practice of management of psoriasis, because there was less chances of TB reactivation and less chances of anti-drug antibody formation. So this drug was found to be extremely effective. But of course these biologicals, they come with a cost, and there has been continuous development and continuous progress with regard to clinical development of various such molecules, and the molecules like ustekinumab and brodalizumab was also in the clinical development program, and the various newer biologicals are still in the pipeline, and they have been tried, and a lot of clinical trials has been going on. So our search for the ideal molecule in psoriasis still continues, and there has been a lot of research in the field of dermatology with regard to that.
Since many molecules are at play, it is sometimes very difficult to pinpoint pathogenesis on a single molecule. Dr. Pandey, do we foresee a future where this biological therapy will be within a reach of a common man, maybe in next 10 decades or 3 decades or 4 decades?
Yeah, let's hope so, because these are expensive molecules, and most of them are generated in the Western countries. And it takes little longer time for this molecule to come in India at an affordable cost. Although they might be available, but the cost remains a problem. But since we have a lot of patients of psoriasis in India, I hope with the newer molecules that they come, the price will not be an issue in the future, and we expect the biologicals to be available to us at a lesser cost.
Now, I will shift my focus on pemphigus. In yesteryear, we used to give high-dose corticosteroids,
Yes,
and
yes.
we all are aware how dangerous corticosteroid treatment can be, where we used to give 100 milligram or 120 milligram of oral corticosteroids. Patient used to bloat up, Cushing goit, acid peptic disorders, osteoporosis. But now we are starting with a medium dose of corticosteroids, say 40-50 milligram, and other immunosuppressive agent adjunct therapy. Plus now we have biological therapy, as we have discussed
Yes,
in psoriasis.
absolutely.
Now we have a chimeric monoclonal antibody, that is rituximab. How you see things? Can we totally stop steroid and immunosuppressive drugs and preferentially start make rituximab as a first line treatment in pemphigus or other autoimmune
yes,
diseases?
Yes, yeah, I hope so, because earlier we have seen patients of severe pemphigus that has been infused with a lot of corticosteroid, oral and intravenous corticosteroid, and so many immunosuppressive agent has to be used, and we have seen lot many patients developing severe side effects, and particularly patients dying because of the reactivation of the tuberculosis.
Correct.
They were not dying because of the pemphigus, but they might be dying with the complications of the immunosuppressive therapy.
Correct.
So for such patient, rituximab has turned out to be the boon, and that has changed the practice of management of pemphigus in India in particular. And many of the Indian dermatologists have switched to this biological, that is rituximab. It has those some safety concerns, but the molecule I think we have reasonably used in many patients of pemphigus with reasonable efficacy. And the good thing about this particular molecule is that they has to be used not on a continuous basis, but we
Yes.
use it in a like we infuse it with the RA protocol at one setup and after 14 days with another. And we have a good experience of post-treatment remission period to the
Correct.
tune of 3 to 4 years average.
Yes.
And that's a good period of time where you can keep your patients away from the immunosuppressive therapy, and particularly the children and the unmarried people are going to get most of the benefit
Yes.
out of it. But
Dr.
still our search for the better molecules in the management of pemphigus do continue.
Dr. Pandey, do we have any particular dosing schedule only for pemphigus? Because since we have extrapolated the dosing schedule from either RA protocol or from lymphoma protocol, are there any publications or trials in line where a disease like pemphigus oriented dosing schedule has been planned or given, or like we can tweak the dosing on our own? There is something in the line?
Yeah, in India, most of the time we use the protocol that suits our patients, because this is an expensive molecule, and as compared to the practice in the Western, our practice of using the molecules is slightly different.
Yes.
So to me, as of now, the lymphoma protocol or the RA protocol seems better. And if at all there is a relapse with the pemphigus, we have a liberty of reinfusing this thing. Unlike in the Western countries where they give the intravenous immunoglobulins as an add-on therapy to the rituximab. So in my opinion, rituximab therapy has been a good standard reference therapy as of now in a country like India.
Yes.
But as I said, I am not aware of the molecules that has been in the pipeline, but still the search for the better molecule I think does continue.
Correct. Now I would like to switch over to vitiligo. How has your vitiligo practice changed in recent years? How you used to manage previously when, say, you are a fresh postgraduate pass out student and establish a practice, and now in 2020, how you are seeing the change in your practice?
Yeah, I think there has been a trend in the management of vitiligo as well. There's a lot has changed, but one thing I guess has not changed is the use of PUA therapy and the narrowband phototherapy. This was actually used in when we were a resident, and that still continues. One more addition in the armamentarium of phototherapy is an excimer laser, and that has to be found to be pretty useful in the management of
Yes.
vitiligo. With regard to the immunosuppressive agent, in addition to steroid or as a steroid sparing agent, we are more opting for the drugs like azathioprine,
Correct.
Which are offering a reasonable effect on
Satisfactory
the
response in
satisfactory
repigmentation.
response, not just on the stability of the disease,
Yeah.
but also in terms of repigmentation.
Repigmentation
So if you have
also.
any other experience with other molecules, you can just share with us.
Yeah, nowadays we exclusively we are now shifting over to azathioprine, and initially I used for a short duration, say a 2-month course of oral corticosteroids, and later on then put the patients on azathioprine and narrowband phototherapy or phototherapy based at home also. So now there is a liberty to treat disease with less drug, and with though vitiligo, though azathioprine do have a risk of myelosuppression, but in a good drug is safe in with a safe physician. That's what I feel.
I think all drugs do come with side
Yes.
effects, but if it has been managed by a very qualified and a learned dermatologist,
Yes.
I think that's the message that these
Yeah.
drugs can be used effectively
Yes,
for the treatment
yes,
of
yes,
various
yes,
disorders.
yes. Apart from making disease stable, how has energy-based devices helped in vitiligo, especially localized patches and few resistant lesion? Do you still go with immunosuppressive, or you try to do something else?
No, with localized disorders, localized disease, and if the patient can afford, and if he can come to your clinic twice or thrice a week, I think I will go for the excimer lasers.
Yes.
Because that is pretty safe, even in pregnant women and in children's as well. But for the localized recalcitrant patches that is not responding to immunosuppressive therapy, we can definitely go for the surgical modalities or for melanocyte restorations, like suction blister grafting or melanocyte keratinocyte transplantation. I think that has been also the trend. If in cases of recalcitrant patches of vitiligo, we can definitely go for it.
What I can summarize from your talk on vitiligo is we should first try to stop the autoimmune disease,
Yes.
and new term what I've learned from you is you try to restore melanocytes.
Yes.
This is a very good strategy to treat vitiligo. You stop the disease autoimmune process and try to restore the melanocyte biology as it was previously.
I think
Before
Bhushan, you have been the expert in the field of this PRP for the treatment of androgenic alopecia, and
Yes.
there has been a lot of changing things happening in the field of medical trichology,
Correct.
not just cosmetic trichology, but medical trichology
Yes.
or surgical trichology. So, what's your take on the recent trends?
Yeah, there have been lot of hype and lot of noise around use of autologous platelet-rich plasma. However, with my foot down, I would like to say that it is an adjuvant treatment. As of now, it doesn't act alone on its own. Medical treatment is the mainstay of treatment. Your oral dutasteride and minoxidil for a good duration of time works very nicely. Say a good minoxidil course and a good oral dutasteride course for say 6 to 8 months gives you a very sufficient growth. And obviously there is a trend of to top it with PRP. So PRP is an adjuvant. It is not to be used standalone, and I think you should not offer it as a cure for androgenetic alopecia. What we are seeing the trend, and it's very disturbing, and many coacs and other non-dermatologists or non-allopathy doctors are also promoting PRP in and out without knowing its scientific basis. So that is a dangerous trend, and we as a qualified dermatologist should try to separate wheat from the chaff.
What's your safety concerns with regard to the use of oral finasteride in the management of androgenic alopecia?
As of now, this so-called post-finasteride syndrome, and I have used in my last 8 years of practice, I hardly a 3-month course or a 4-month course, it doesn't have any so much bearing on this post-finasteride syndrome. Majority of this are all patients who are more say anxious patient who have a going through Google Baba, and they read about this post-finasteride syndrome and they get panicky. So most it is like a invited disorder rather than a true disorder resulting from.
Do you agree that there is a lot of dermatologists are doing hair transplant surgeries, and that has actually changed the face of trichology? So that has been recent positive trend, and many dermatologists are doing, because
But it
what's
is
your take on
it is setting a negative trend also. We are offering hair transplant as a daycare procedure, which is not, as you said in one of the forum, that it is not a good trend. We are offering 4,000, 5,000 graft in a single setting of 8 hours, and it's like a major surgery for the patient. So much of anesthesia, so much of anxiety, and we have recently read about reports of death also among this patient. So somewhere we have to get trained adequately.
Yes.
Like what we do, a plastic surgeon gets a proper training during his MCH training.
Yes.
We all should acquire that skill with good amount of investing of time.
Yes.
And at least a good 2 years of hands-on training is needed before you offer it on commercial basis.
Yeah, exactly.
Yeah.
So hair transplant is definitely one of the effective procedure, but it has to be done with caution, in the safe hand, admitting patients, and with all precautions that has to be taken.
Yes. Nowadays we have seen that in a minor OT room also the hair transplant procedures are being done. which is may not be in the no infection control, and what many hair transplant surgeons shows are only the positive result, but where are the negative results? How many cases have gone bad? That no one negative data is still lacking in hair transplantation.
Bhushan, one more thing is there has been a lot of things with regard to use of social medias and WhatsApp for dermatology consultation, that people feels that the dermatology consultation is like a visual consultation.
Yes.
And you just see the photographs and you can treat the skin disorder. Do you think this is a good trend that has been set in, or you advise some
My
caution?
idea of social media is very clear. Social media is only for between two doctors. It is not between a doctor and a patient.
Yeah.
So I don't promote social media exchanges between a doctor, physician and a patient. It is only strictly between cases, though there are ethical issues of sharing images as per privacy laws, though there are issues, but still I still promote social media between only two health professionals only.
Yes, so definitely the use of WhatsApp and other social media needs to be curtailed.
Yes,
as
yes.
far as online treatment of the
Yes,
skin
online
disease is
treatment,
concerned.
yes. The teleconsultation is entirely different from your social media, where in teleconsultation the two ends both have the physician.
Yeah, it's an integrated practice.
Yeah, it is an integrated practice. It is
Organized
a
practice.
organized practice. But whereas in WhatsApp and your Facebook, all these are like shaky grounds where you never know if you prescribe azathioprine off-label without investigation, patient continues to take it for 6 months without any investigation. Who knows, he may land in bad myelosuppression.
Yeah. So that's what I think we see in the lot of changes that has been happening, and lot of practice trends changing in the end. Hope these changes will also occur in the near future.
Correct.
And dermatology is a continuously evolving branch with so many sub branches.
It is still in
attached to it.
infancy, I can say.
Yeah, but it's growing and by leaps and bounds,
yeah.
and that is a good trend for dermatology.
Yes,
as well.
correct. Thank you, Dr. Pandey.
Thank you, Bhushan.
Thank you.
quite a lot.
Yeah. Then
जो ऐसे पीछे है कि ऐसे ठीक है?
हाँ ऐसे
ऐसे
ठीक
भी
है
थोड़ा आगे
but
पीछे
don't
हो
slouch.
Start. Hi. So I am Dr. Aseem Sharma. I am from Mumbai, and with me are two beautiful ladies to my right, Dr. Rachita Dhurat and Dr. Madhulika Matre, both from Mumbai. So today I would like to burden you with some questions on trichology. So my first question is to you, Dr. Madhulika. Why do you think there is a separate need for a field like trichology? Why the separate need?
So, see, in today's day and age, the field of dermatology is not just restricted to clinical dermatology or dermatopathology per se. It has expanded to include newer subspecialties such as, say, trichology, vitiligo, pigmentation, dermatosurgery, etc. And as an individual who has to cater to a variety of people, it has now become much more essential to acquaint yourself with the skills required for each of these, or maybe a particular chosen focus area that you want to super specialize in per se. So out of all these options, I think trichology forms a very major spectrum, part of the spectrum especially. So it's a good arena to establish a practice in, or maybe just super specialize in per se.
And for those of you who don't know, both Dr. Madhu today's day and age.
So in today's day and age, the field to get into the field of trichology, since I got this observership under, so a good platform for individuals to go and acquaint themselves with the latest technology or what latest research is happening in the field of trichology. There are also paid fellowships that you can opt for abroad, but they are not easy to come by. So they are a little expensive. So for young dermatologists, maybe a little later in life, they can go for one of those.
And last, just to continue, certificate courses, what is your take
a lot
on
of
that?
institutes do offer short-term trainings and certificate courses, and the details of which are freely available on their respective websites. So yes, of course.
So there is a certificate course that is run by ma'am herself with no conflict of interest, the Trichology Update Training Institute. Ma'am, what does that certification entail? How is it different from the other certificate courses that are available?
See, in this certificate course, we not only give the didactic lectures, we actually give the cases, and we tell them to, now look, you need to examine how you examine in your clinical practice, and you write down the prescription how you are going to write in your practice. And then we analyze their prescriptions, and based on the prescription, then we tell them now where you have gone wrong or where you have to be focused on to the various aspects. So this is a unique training that we give one-to-one training. Apart from this, we also conduct a national conference every 2 yearly, and we are into the 5th year of this conference, which is popularly known as Trichology Update, which is happening from 12 to 14 June 2020. And
we invite international faculty so that we get to learn from these global expertise everything about in hair disorders. So those who are interested, like Madhulika said, that those who want to learn into this field, they should attend the various CMAs conducted by IIDWell, SIG group of IIDWell, Trichology Update. Even they should go internationally and attend such kind of the conference. Then only you will get a good confidence how to treat your cases. Just knowing that minoxidil, finasteride, dutasteride is not enough in this subject. You need to know in-depth knowledge about trichology.
So point to be noted, in today's day and age, just knowing about minoxidil, finasteride and just a few other things, topicals, peptides doesn't really help. You need to know the whole game. You need to understand why, how and what happens in trichology. So now we're acquired with the knowledge in trichology. We now know where to go. Now we are trained. Now I want to open up my setup, which brings us to the main question of today's session. So ma'am, how should I go about starting a practice in trichology? What all do I need to buy?
See now, Asim, suppose you take your example. You suppose you have gained knowledge about in trichology.
Yes.
Now people start recognizing you as you are a best trichologist. Correct? For that, what you will do? You will post on your social medias, okay, various social media. You deliver talks on hair and various forum. You want to say the laser for hair reduction,
yes,
or in general lasers?
Low level light laser, ma'am. A laser for hair therapies.
So, if you want to go for the low level laser therapy for hair loss, you first build up your practice, because these lasers are not at economical cost. It has its own cost. So first you build up your practice, because in the beginning patient will not embark what you say. Yes. If you tell them to buy something in 1,000 rupees, they may not buy it. So once you get the confidence that no, I can convince my patient that low level laser therapy is good, that time you can venture into low level laser therapy. I started my practice since last more than many years in this field, but I venture into low level laser therapy now when I know I have seen the results of low level therapy. I have read about the various publications and I know now it works.
So where it fits in the scheme of things. So don't be in a rush to buy everything for the clinic. It's the same as when you're setting up a dermatology unit or a dermatology clinic. Invest more time in learning about the other skills in trichology like PRP and microneedling. Invest more time and research into that, and then finally pick it up. So any closing pointers from both of you? Ma'am, any closing pointers for the audience?
For the newcomers, I would say that if you want to come into the field of trichology, you have to know the in-depth knowledge about the trichology, hair disorders. Having a superficial knowledge will not take you on a long way. Keep on reading, reading and reading. Make some innovation out of that. Present your cases or work in a various forum. That will give you the boost, and then you will keep on going on this field.
So wonderful. Those are pearls to live by actually. Dr. Madhulika?
I totally second what Dr. Rachita just said. There are no shortcuts. Right, the path, the destination is the same for all of us, but the paths that we take to reach that destination may actually be different. So find your own path, see what works for you, see what suits you better. If trichology,
really meet them, because that's the only way they will call you to their centers. Just by emailing people, it doesn't really work that way with in trichology.
So see you
in
TU. In June, TU 2020.
Thank you.
that covers the UVA and
Yeah.
UVB as well, and infrared also, right?
Yes.
पंद्रह मिनट का सेशन है, चलो ठीक है, 15 मिनट तो बात करें।
15 मिनट नहीं कर सकते हम, मुंह बंद रखो, 5 मिनट। रेडी?
संदीप सर फोटोज हमारे। Good evening everyone. Welcome to DermaCon 2020 Pune and Derma TV. I'm Dr. Meenaz Khoja, dermatologist from Pune.
Hi, I'm Dr. Gulhima Arora from Delhi, and we're going to speak on sunscreens this evening. So Meenaz, would you like to begin?
Yes, sure. So we've heard a lot of hue and cry about sunscreens. So we're going to discuss it in a little detail just for the common population to understand what exactly is sunscreens. So what are sunscreens? Basically, they prevent sun damage to our skin by protecting and forming a layer on the skin, and that protects the harmful radiation of the sun as well as the infrared.
So we've got a sun block and a sunscreen. A sun block is when it's applied on the skin and it blocks the sun rays. Whereas if you talk of sunscreens, they basically either absorb or reflect or scatter light. And they are divided into physical. We use them in polymorphous light eruption, photodermatitis, lupus erythematosus, and even in cancer patients who have some sort of a cancer, especially renal cancer, we do advise sunscreens to prevent any kind of worsening of the cancer.
Also, using it when you go on a holiday to the beach is very important because you can get your skin burnt. So you've seen sunburns and all that stuff. And we personally think that even the Indian skin type may sometimes burn or get a sun rash kind of a thing where you have flaking after maybe a water park holiday or something like that. So you must use a sunscreen even when you're on a vacation. There's no vacation from sunscreen.
That UVA rays are the ones that cause all kinds of photoaging and cancers, and the UVB light is the one that causes sunburn. So we must protect our skins from both of them. And with ozone depletion now, it's even paramount that we have more and more broad spectrum sunscreens. So Dr. Meenas, would you like to tell the audience about how we detect the efficacy of a sunscreen?
So the efficacy of the sunscreen is detected by a parameter known as sun protection factor, or the SPF, that most of you would be seeing on sunscreens available over the counters. So anything for Indian skin type, anything above 15 to 30, 15 to 30 is good enough for Indian skin. Also another method is the star rating, that is for UVA protection, that is 1 star, 2 star and triple star rating, mainly for the UVA radiation. And also for IR, now they mention infrared radiation also on the sunscreens. So look for something that goes for UVA, UVB and IR.
So when we advise the patient regarding how to apply a sunscreen, I think we must reiterate and tell them that the minimum dose required is about 2 milligrams per centimeter squared, which is very seldom actually applied by anybody because it becomes cosmetically unappealing. But then we have to tell our patients that it is of importance to keep reapplying your sunscreen every 2 to 3 hours, whether indoors or outdoors, because the ultraviolet lamps in the house can cause equal amount of damage. Also tell them whether it's broad sunshine or whether it's raining or whatever the weather be, one must apply a sunscreen, especially if you're treating a dermatological condition.
Also for aging, that really helps the sunscreen application. So if you've been applying sunscreen for say 5 years or 10 years down the line, and if you compare your skin with your counterparts and they've not been using a sunscreen, you'll see that your skin is more maintained, more smooth, more uniform texture, and the counterparts without the sunscreen will be a little crinkled or photo damage or pigmentation and looks a little rough. So a sunscreen goes a long way in anti-aging as well.
True. And as dermatologists, it's important to tell our patients about what kind of sunscreen to choose for their skin type, because there's such a plethora of sunscreens available in the market, and it's an OTC product. Yeah. So it's important to tell them if their skin is oily, they need to use a certain type like a gel, or
if their skin is dry, they can use a lotion based or a cream based sunscreen. Acne prone skin, definitely gel type.
Yes. So sunscreens are not without side effects, Meenas. So they can have their share of side effects. And contact dermatitis, irritant contact dermatitis, or even allergic contact dermatitis to one of the ingredients is something that is there. And one must choose a paraben-free sunscreen as far as possible, because now there are reports of nanoparticles which are coming in as sunscreens, which can lead to some kind of carcinogenicity. So you have to tell your patients to, if they're choosing an OTC product, to choose a paraben-free sunscreen.
All right. So the best sunscreen in this viewpoint is a physical blockade. So either tie a scarf around your face. In Pune, I'm sure you know the Bandit Queen style, where only your eyes are seen and nothing else. And also you can use an umbrella, a black one with a silver lining inside. So that's the best kind of protection. But sometimes it's not feasible to use it everywhere. That's why the cream-based or the application-based sunscreens come into play. Also, you can have a little burning of the eyes around when you apply the sunscreen around the eyes. eyes and around the eyes and on the neck is something that you should not miss out, especially because if you're using it for anti-aging purpose, because these are the areas we tend to miss out while applying a sunscreen.
Yes, and not to forget the other exposed areas like the hands and the neck, because those two are exposed and you don't want your face to look 10 years younger than your hands and neck. So
Absolutely, yeah.
those must be taken care of as well. Also, the other the ingredients, as we've already spoken of, though you said we must apply a physical sunscreen, they are a little cosmetically unappealing because it gives a whitish hue. We do have transparent sunscreens also now, especially for our male patients who feel it better to use something which is not showing on their skin.
Absolutely.
And lotions are good for hairy areas. We must not forget the hairy areas too, like the beard in males if when they are using a sunscreen. So advice regarding that also has to be
there
given.
are sprays now, so if you're like too lazy to take lotion and rub it on your face, you can just spray the sunscreen and that works well too.
Yeah,
so
so there's a word of
sprays,
caution with sprays. One must not inhale it.
Aerosols,
because, yes, aerosols. One must not inhale them because you can cause more harm than good. And an ideal sunscreen would be an inert one, which is fragrance free, cosmetically elegant, and free of parabens. And one must choose a sunscreen which is non-toxic, non-genocytic, non-cytotoxic as well.
And there are myths about vitamin D deficiency being caused by sunscreens, but see, for vitamin D production in your skin literally produces vitamin D itself. So you can just expose maybe just your leg or whatever, just one tiny bit of skin exposed to the sun daily for about 10 minutes, I think does the job. So vitamin D deficiency caused due to sunscreen is really a myth.
There are reports, yes, I agree, it is more of a myth. It's more of diet and supplements that actually give rise to the deficiency rather than applying a sunscreen. So that's a myth.
So thank you so much for joining us on Derma TV and IIDVL DermaCon.
Thank you so much. Have a nice day and conference ahead. I think we were great. Without
you.